هلا General Ministry of General Director of the Health Ministry بس مجرد تعديل فيها النص General Director Ministry of Health Region General Director of the Ministry of Health and Health Region هلا عربي أبدأ فرح مو مفرح أنا قلت خلاص ايه في بعد مختلف
أول ما تهدف
هلا يس هي واضحة بس أنا واضحة ها؟ هو جاهزة أساسا أي تبي نعيد من جديد الرابع؟ عشت إيه كلها بس لا أنت بس هذه نعم شو النظام واحد 8
الو تيست اوكي ثانك يو
عليك
أي المايك اللي ما يشتغل عبد الله
اللي مع حنان
أنا قفلت مو ما داري بعشرة أكيد يشوف قال لي
تيست
هذا أنا بتكلم بالسبيكر لا هي بالشعار اللي وريكم واضح فاهم علي؟ ما أبي
Warmly, please welcome Mr. Sultan Saeed, General Director of the Ministry of Health Branch in Hail Region, and the leading patron of this International Lifestyle Medicine Conference. Thank you for your insightful speech, Mr. Sultan Saeed. We truly appreciate your presence. Please join me in an extending warm welcome and heartfelt welcome to Dr. Abdullah Mferreh Asiri, Deputy Minister for Population Health at the Ministry of Health. A distinguished national leader whose vision and dedication continue to elevate the health and well-being of our population. We truly are honored to have him with us today. Thank you, Dr. Abdullah Asiri, for your insightful contribution and tremendous value you added to this session. Let us warmly welcome Dr. Jalal Awaisi, President of the Saudi Red Crescent Authority, leader whose service and impact are truly inspiring. Thank you, Dr. Jalal, for your visionary leadership and the inspiring perspective you shared with us today.
حطه بالعربي عويسي عشان ما هو عدل من الرياض على هذا المفرح. طيب اللي بعده
Please join me in welcoming Dr. Shayma Abdel-Al from the College of Medicine, King Abdulaziz University, an exceptional academic voice dedicated to advancing medical education and community well-being. Thank you, Dr. Shayma, for your enlightening contribution and meaningful perspective you brought for us today. That concludes our session for today. We will start with our second session shortly. هذا تكون بعد شيماء قبل
دكتورة شيماء. Now we'll start our honoring خلينا نقول honoring session or honoring of the speakers or the honoring of the keynote speaker with Dr. مشعل نايس. بس لا تقدم خلاص
أقول دكتور مشعل نايس.
يس هنا أجي وأقول بليز طبعا بالعربي ممكن، أو سعادة مدير عام فرع وزارة الصحة منطقة حائل الأستاذ سلطان بن ناصم سعيد، ندعوك إلى الستيج. تفضل لفقرة التكريم.
ثلاثة أيوة.
نعم. الأونورينج تكريم. طيب وأنا بدي أبو ناصر، بعدين أنا I will call please دكتور عبد الله العسيري، دكتور رجال عويسي and دكتور شيماء. بعدين we will just now we will conclude our first session and we will start the second session. خلاص. نعم. خلاص. Thank you, دكتورة شيماء for great talk or for the speech. بعدين أكون جنبك على طول ندخل. And now we بالضبط.
حلو مثل ما
كذا ممتاز.
حلو ما في مشكلة.
أنا أدخل الآن فقرة التكريم المتحدثين الرئيسيين.
إيه بالعربي.
أستأذن سعادة مدير عام حائل. تفضل على ستيج.
ضيوفنا الكرام.
ابتداء تكريم الله الوزيري شيماء عبد العزيز الدلال. الحمد لله استلموا شغلها. أنا صرت مكتوب امبارح.
إيه حلو.
Now we will start our second session. خلاص.
Now we will
نسيت ورقة السيارة.
غالبا we will start our second session بعدين يبدأ المحادثة.
وأنا محمد صرت غير على السيشن الثاني.
لا ما صرت غير، لا بس إنه لا كانت الدكتورة شيماء كلمته أنا أشكره. تجي عفوا يجي دكتور مشعل
جنبي يقول الان راح نكرمها.
You need some pills تاخذ الحين؟
يس احسن.
وعلبة ما شربت عشان شربت جيب لك.
باخذ لك حبتين.
أخذ اثنتين أنا. هذا من علبة ما شربت. صعب. صعب. تدري ايش الجميل انك تسوي كذا؟ ليش يقول لك بدوي؟
هذه بتكون نص ساعة. عشان تكني بس راح.
ايوه.
نتدرب على السيشن شوي.
كيف؟ يعني ما ادري وين رحت هناك ولا شنو. هذا ممكن تسوي حركة.
لا ترى نظام شلون؟ اسفت كله.
اي صح. قرايه يعني.
انا تعلمت.
If medical school taught lifestyle habits first, half of us wouldn't have survived the stress semester.
True. Imagine graduating knowing how to sleep, it will and manage stress. It will be revaluation.
Okay, then what habit do you think should be mandatory in medical education?
We will dive into that. Our next session moderator, Dr. Mishal Anais, Scientific Committee Chairman, Consultant Clinical Pharmacy and Internal Medicine Pharmacotherapy. Welcome, Dr. Mishal.
السلام عليكم. السلام عليكم ورحمة الله وبركاته. Good morning, everybody. I will moderate this session, the session number 2. I'm Mishal Anais, the Scientific Committee Chairman, and we'll start our first session in the scientific program. Our first speaker will be Professor Salman Rawaf. So on the bio of Salman, please welcome with us Professor Salman Rawaf.
انا اقول نيكست سيشن، كل السيشن بيتكلم عنها مع المدير. وانا قلت لكم الاكسبلور ده او النكست سيشن مودريت.
يلا وخلي الصيغه في التساؤل كذا، عرفت كيف؟ وريني كذا، عرفت كيف؟ ما ادري وش الجمله، بس خلي صيغه التساؤل.
Blue zones show us that long life is built on community purpose and everyday habits. Small actions done consistently can transform how we live. What's one blue zone inspired habit you will add to your routine?
Okay, what do you mean by blue zone?
We'll explore that with our next moderator, Dr. Michal Anais.
Hello. Again, I will moderate this session virtually with Dr. Wayne, designer. He's the Chief Medical Officer for Blue Zone Health and practicing lifestyle medicine physician, past president of American College of Lifestyle Medicine. Please welcome with us Dr. Wayne. Do you hear me, Dr. Wayne? Is it okay? You can start. The stage is yours, and we will count the time. Thank you.
Healthy communities do not happen by accident. They are built by habit support, shared purpose.
And when communities thrive, people thrive with them.
What small change that could be strengthening your community well-being?
Our next session moderator will guide you through that. Please welcome Dr. Thamer Al-Nasr, diabetic food specialist and director of the Diabetes and Endocrinology Center at حائل Health Cluster, head of the diabetic food unit at King Salman Specialty Hospital. Please welcome.
Thank you. Thank you for the nice introduction. I will moderate the last session for today. I'm Mr. Thamer Al-Nasr and our first speaker and so on. Thank you. Second, if you notice, my dear and all the audience, we have another QR code in the screen for the open dialogue. Please scan the screen. Mohammed.
That concludes our last session for today. Thank you all for being a part of this inspiring first day of Hail's 4th International Lifestyle Medicine Conference. It's been a day full of insightful sessions, engaging discussions, and new connections, all reminding us of how small lifestyle changes can create big impacts on our lives and health and well-being. A sincere thanks to our incredible speakers, moderators, and of course, to all of you for your energy and participation. We've only just begun. Tomorrow brings more exciting sessions and opportunities to learn and grow together. Until then, enjoy your evening, recharge, and we'll see you tomorrow for another impactful day. Thank you.
Blue Zone show us that long life is built on community purpose and everyday habits. Small action done consistently can transform how we live. What's one Blue Zone inspired habit you would add to your routine?
Could you explain what do you mean by blue zone?
Let's explore that with our next session moderator, Dr. Michelle Anais.
قصيد بيناتهم قاعدين
شعار طلعنا.
قصيد بيناتهم.
لا طفيناه.
احنا نبي الابروفل عشان يقولون.
Test. I would like to announce for all the audience, we have many QR code here. If you noticed, we have a QR code for the questions, QR code for the evaluation, and QR code for the open dialogue. The first open dialogue, it will be Hatem's Health, the Saudi Vision, and here we have Al Badr and Aja Glow. So please scan the QR code here and you will find all the information to fill in. Thank you. This is test. Okay, this is test. We will repeat again the announcement during the session. Thank you.
أول ما تهدى أنفسنا تهدى الدنيا معنا. الحياة ليست سباقا بل رحلة نمضي فيها بخطى ثابتة. كل يوم جديد فرصة لبداية أفضل نختار فيها خطوة نمشيها، وجبة نتذوقها.
ذكر الله وجلت قلوبهم وإذا تليت عليهم آياته زادتهم إيمانا وعلى ربهم يتوكلون.
أول ما تهدى أنفسنا تهدى الدنيا معنا. الحياة ليست سباقا بل رحلة نمضي فيها بخطى ثابتة. كل يوم جديد فرصة لبداية أفضل، نختار فيها خطوة نمشيها، وجبة نتذوقها، نوما هادئا نستعيد به توازننا. النشاط البدني ليس عبئا بل هو حياة، والتغذية الصحية ليست حرمانا بل وعيا واختيارا. أما النوم فليس ضياعا للوقت بل وقود لأيام أجمل. وعندما يزداد التوتر خذ نفسا عميقا ودعه يمضي مثل نسمة الربيع. في العلاقات الطيبة والضحكة الصادقة ترفع الصحة قبل المزاج. وابتعد عن كل ما يسرق من عمرك بهدوء. عش 80 ليس عدد سنين بل أسلوب حياة نبيل. من حائل تنطلق الرحلة وتلتقي المعرفة في مؤتمر حائل الدولي لطب نمط الحياة 2025. جودة حياة برؤية وطن.
Assalamu alaikum. Good morning, everyone, and welcome. My name is Abdullah Al-Ghassab, accompanied with my co-hosts Hanan Al-Hindi and Abdul Majid Al-Muka. We are members of the Executive Committee of Hail's 4th International Lifestyle Medicine Conference. Thank you for joining us today. We are thrilled to have you. Being a major part of our ambitious 2030 vision, lifestyle medicine is a key component of achieving the highest quality of life possible. With the scientific evidence that proves small changes in the individual's lifestyle could improve the health and well-being drastically. Lifestyle medicine is also considered to be the foundation of health, as it is using evidence-based therapeutic lifestyle medicine. It's also based on 6 main pillars that we could apply to our day-to-day lives. Those being sleep, nutrition, physical activity, stress management, social connections, and avoiding risky substances. Moreover, it is recognized as an effective approach in combating chronic diseases such as heart diseases, diabetes, obesity, and high blood pressure. Now, not only you'll be able to hear from our excellent range of speakers, you'll also be able to connect with them through the QR code provided on the screens when the session starts. We also suggest you to check out the activities we have for you between the sessions, like the 80 seconds walking stations, the open dialogue stations, get to meet and learn from Mr. Aja, our interactive AI avatar, and much more. All of which makes for an exhilarating experience that will surely be an eye-opener for how lifestyle medicine can make differences everywhere it is being applied. Without further ado, I'd like to introduce Mr. Sultan bin Nasr Saeed, General Director of the Ministry of Health in Hail region. Please welcome.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. سعادة وكيل الوزارة للصحة السكانية الدكتور عبد الله عسيري، سعادة رئيس هيئة الهلال الأحمر الدكتور جلال العويس، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا وأهلا وسهلا بكم في عروس الشمال حائل، والحمد لله على سلامة الجميع اللي جايين من خارج المنطقة، فأهلا وسهلا بكم. نلتقي بكم اليوم أو في هذا اليوم المبارك في النسخة الرابعة لمؤتمر حائل الدولي لطب نمط الحياة تحت شعار عش80. لا يخفى على الجميع حرص حكومتنا الرشيدة والقيادة الحكيمة على كل ما فيه منفعة ومصلحة لكل من عاش على أرض هذا الوطن الغالي، لتأتي رؤية سيدي ولي العهد صاحب السمو الملكي الأمير محمد بن سلمان بن عبد العزيز حفظه الله، والتي كان من أهدافها التحول الصحي وتحسين نمط الحياة الصحية وجودة الحياة والوصول إلى متوسط عمر الإنسان إلى 80 سنة. من هذه الأهداف والرؤية الطموحة والملهمة آتتنا فكرة المؤتمر، ونطمح إلى الوصول بصحة الفرد للمستهدفات المنشودة بإذن الله. مؤتمر حائل الدولي لطب نمط الحياة هو تجمع علمي واجتماعي تأسس وتطور وازدهر عاما بعد عام، ووصل إلى آفاق الأرض في مشرقها ومغربها بفضل الله، ثم متابعة ودعم سمو سيدي أمير المنطقة الأمير عبد العزيز بن سعد حفظه الله، ومتابعة من سمو نائبه الأمير فيصل بن فهد بن مقرن، وأيضا متابعة حثيثة من قبل معالي وزير الصحة الأستاذ فهد الجلاجل والزملاء في وزارة الصحة في كافة الوكالات والإدارات. كل عام تتضافر الجهود من جميع القطاعات الحكومية والخاصة في منطقة حائل، مشكورين لجعل هذا الحدث تظاهرة علمية صحية ومجتمعية عالية المستوى. نفتتح هذا الصباح البرنامج العلمي للمؤتمر، والذي يضم نخبة من المتحدثين والعلماء من المملكة العربية السعودية والولايات المتحدة الأمريكية والمملكة المتحدة ومصر والسودان واليمن والجزائر والهند وبلجيكا، المتخصصين بطب نمط الحياة بجميع محاوره الرئيسية، بعدد يزيد عن 50 متحدثاً، لإضافة الكثير من المعلومات والدراسات العلمية الحديثة المحكمة للبرنامج العلمي على مدار 5 أيام، ما بين محاضرات ومناقشات علمية وورش عمل في هذه القاعة وسط أحضان طبيعة حائل الخلابة. أتقدم بالشكر الجزيل لكل من حضر وشارك وسجل ولبى دعوتنا من المتحدثين والحضور والزملاء في جميع لجان المؤتمر، ونتمنى لكم برنامجا علميا ثريا وممتعا ومفيدا. في الختام نأمل من سعادة المتحدثين والمتحدثات واللجنة العلمية حصر التوصيات العلمية في نهاية البرنامج العلمي لمراجعتها وتنفيذها ونشرها لتعم الفائدة العلمية للجميع، وتكون حائل مرجعا علميا للعالم أجمع. والسلام عليكم ورحمة الله وبركاته.
Thank you for your insightful speech, Mr. Sultan Saeed. We truly appreciate your presence. Please join me in extending a warm and heartfelt welcome to Dr. Abdullah Mfarrah Asiri, Deputy Minister for Population Health at the Ministry of Health. Please welcome.
السلام عليكم ورحمة الله وبركاته. سعادة مدير عام فرع وزارة الصحة في منطقة حائل، سعادة رئيس هيئة الهلال الأحمر السعودي، الإخوة والأخوات الحضور، اللجنة التنفيذية المنظمة لمؤتمر نمط الحياة، السلام عليكم ورحمة الله وبركاته. أتشرف أن أكون معكم اليوم في افتتاح هذا المؤتمر الذي أصبح من ركائز تنفيذ رؤية المملكة العربية السعودية على مستوى منطقة حائل، من خلال تعزيز كل ما يدعم جودة الحياة في المملكة العربية السعودية للمواطنين والمقيمين. وجودنا معكم اليوم هو لاستعراض التحولات التي تعمل عليها وزارة الصحة من خلال تطبيق مفاهيم التحول الصحي والانتقال من مفهوم العلاج إلى مفهوم الوقاية. ولا شك أن رؤية المملكة العربية السعودية قد وضعت موضوع جودة الحياة في أولى الأولويات، ولعل استهداف زيادة العمر المتوقع للمواطن والمقيم في المملكة العربية السعودية إلى 80 عام وأكثر هو أحد أبرز ملامح هذه الرؤية. الآن نحن قاب قوسين أو أدنى بفضل الله ثم بفضل جهود الجميع في الوصول إلى هذا الهدف. وكما تعلمون أعلن معالي وزير الصحة في ملتقى الصحة العالمي في الشهر الماضي أننا قد وصلنا إلى 79 عام من العمر الصحي في المملكة العربية السعودية، وبقي أمامنا 3 سنوات للوصول إلى المستهدف العام الذي هو 80 سنة. فماذا بعد ذلك؟ يعني هذا الهدف مهم جدا، لكن ليس هو نهاية الطريق. فلذلك نحن بدأنا الخطوات التالية لما بعد الوصول إلى هذا المستهدف، وهو كيف أن يكون الإنسان في المملكة العربية السعودية يعيش هذه 80 عام وهو بأقصى صحة ممكنة. فسنركز حديثنا اليوم إن شاء الله على كيف نغلق الفجوة ما بين الرقم وما بين جودة الحياة. أعتذر. طيب، لكي يتخذ صاحب القرار، وهو في هذه الحالة مركز الحكومة وممثلا بمعالي وزير الصحة، أي قرار صحي يجب أن يكون لديه من البيانات ما يدعم هذا القرار. هناك 4 مسارات مهمة يجب أن تكون موجودة وبأعلى جودة ممكنة لتمكين القرار الصحي. وعندما نتحدث عن القرار الصحي لا نتحدث عن مستشفيات، عن مراكز صحية، عن توفير أدوية فقط، ولكن نتحدث عن الدورة الكاملة التي تضمن صحة المواطن. وكما تعلمون أن 80 إلى 85% من المحددات لصحة الإنسان تقع خارج المنظومة الصحية. فمن المهم معرفة دقيقة بالحالة الصحية للسكان عن طريق قياس عبء الأمراض الرئيسية. وفي هذا العصر مثل ما تعلمون الأمراض غير المزمنة هي المحدد الأساسي للحالة المرضية وعبء الأمراض في المملكة العربية السعودية وفي دول العالم بعد السيطرة التي حصلت في العقود الماضية على الأمراض المعدية. أنماط الوفيات من المؤشرات المهمة جدا التي يجب أن تجمع بياناتها بشكل دقيق ومستمر لمعرفة المؤثرات الرئيسية والاتجاهات. عوامل الخطر، نتحدث هنا عن العوامل الاجتماعية والبيئية التي تؤثر على حياة الإنسان، وهي العوامل الأهم والأكثر تأثيراً على صحة الإنسان. فعالية التدخلات الصحية، عندما نعرف عبء الأمراض، مسببات الوفيات وعوامل الخطر، يجب أن يكون هناك تصور عن ما هو التدخل أو التداخلات التي يمكن تنفيذها للتأثير على العوامل والتأثير أيضاً على أنماط الأمراض وأنماط الوفيات. ليس فقط مجرد أن يكون هناك سبب وعامل، لكن يجب أن يكون هذا السبب أو التداخل الذي يصمم مبني على براهين علمية وليس فقط مجرد انطباعات، لأنه كثير من التداخلات التي تحصل إذا لم تكن مبنية على دليل علمي تنتهي بهدر للموارد وبعدم وجود أي تأثير إيجابي على هذه العوامل أو على هذه الأمراض. قدرات النظام الصحي. النظام الصحي هو جزء يعني من منظومة التداخلات في هذه الأمراض، ليس هو الجزء الوحيد لكنه في الواجهة دائما، لذلك مهم جدا أن يكون صاحب القرار على اطلاع على قدرات هذا النظام في التعامل مع الأمراض وعوامل هذه الأمراض، سواء من خلال قياس القدرات السريرية، من خلال قياس قدرات الناس على الوصول إلى الخدمات الوقائية أو الخدمات العلاجية اللازمة للسيطرة على هذه الأمراض وعلى عوامل الخطورة. أولويات وزارة الصحة أو المنظومة الصحية ككل في هذه الأيام وفي القادم الأيام بإذن الله هي تتركز في 3 ملفات كبرى. الملف الأول هو فجوة العمر الصحي، أي الفرق ما بين عمر الإنسان وما بين جودة حياته التي يعيشها أثناء هذا العمر. البيئات التي يعيش فيها الإنسان سواء كانت مدن، أحياء، جامعات، مدن عسكرية، كل ما يحيط بالإنسان ويمكن أن يسمى بيئة ويؤثر على صحته بشكل مباشر. الأمراض القابلة للإزالة، نحن نتكلم عن ملف عن عدد من الأمراض قد يصل إلى 9 أمراض من الأمراض المعدية، لكنها لها مستهدفات دولية، والمملكة العربية السعودية قاب قوسين أو أدنى من إزالة هذه الأمراض. لذلك كان هذا الملف هو أحد أهم الملفات التي تركز عليها المنظومة الصحية في هذه الأيام وفي السنوات القادمة بإذن الله. سوف نتحدث بشكل يعني مختصر عن هذه الملفات لإعطاء فكرة لماذا اختيرت هذه الملفات بهذه الأسماء. فجوة العمر الصحي، مثل ما ذكرنا نحن وصلنا في المملكة العربية السعودية بفضل الله إلى 79 عام بنهاية عام 2024، بينما العمر الصحي وكان آخر قياس له كان في 2021. العمر الصحي المقصود هو السنوات التي يقضيها الإنسان وهو بصحة جيدة، ليس لديه من الأمراض الرئيسية التي تعيق جودة الحياة. وكان آخر تقدير هو أنه العمر الصحي في المملكة العربية السعودية هو 65 سنة و4 أشهر، وهذا كان في عام 2021. يعني أن الفجوة تصل إلى 13 عام من هذه 80 سنة يعيشها الإنسان وهو لديه ما يتعارض مع جودة الحياة. بالتالي الفجوة لا زالت كبيرة، ولا زال هناك مساحة كبيرة من التحرك للوصول إلى تقليل هذه الفجوة قدر الإمكان. كثير من الدول المتقدمة وصلت بعد عمل عقود إلى تقليل هذه الفجوة إلى ما يقارب 8 إلى 7 سنوات، وهذا إن شاء الله هو ما نطمح إليه خلال 5 إلى 10 سنوات القادمة. مثل ما تعرفون المحددات الاجتماعية للصحة هي العامل الأكبر في تقليل هذه الفجوة، هي العامل الأكبر الذي يؤدي إلى الأمراض وعوامل الخطورة التي تؤثر على جودة الحياة، وهي في معظمها سلوكية بيئية. سلوك الإنسان والبيئة المحيطة به هي ما تحدد صحته. هناك أشياء ممكن أن تكون لها تداخلات سريعة ومبنية على البرهان تستطيع أن تعدل في هذه العوامل، سواء كانت عوامل بيئية أو تأثير على سلوك الإنسان بشكل مباشر أو غير مباشر ليحافظ على صحته. وهناك أشياء لا يمكن التدخل فيها بشكل سريع وقوي، مثل العوامل البيئية العامة مثل التغير المناخي، مثل أيضا بعض العوامل الوراثية التي تستدعي إلى برامج طويلة الأجل لمحاولة التعديل عليها. لكن في النهاية هناك حزم مبنية على الأدلة ممكن أن تؤدي إلى تقليل هذه فجوة العمر الصحي. بعضها يعمل خلال أشهر إلى سنوات على حسب الجهد المبذول فيه، وبعضها يحتاج إلى فترات أطول من ذلك. لذلك كان من أهم المفاهيم التي تعمل عليها المنظومة الصحية هو مفهوم أن يمكن الإنسان من اتخاذ قراره الصحي بنفسه، أن يعرف ماذا يجب أن يفعل، كيف يحافظ على صحته، كيف يمنع حدوث الأمراض التي يمكن منعها عن طريق تعديل السلوك، عن طريق تحسين البيئة المحيطة فيه، سواء كانت بيئة اجتماعية أو بيئة فعلية حسية. كل هذه الأشياء سيكون لها الأثر الأكبر بعد الله، ومثبت علميا على أن العمل عليها هو ما سيفعل أو ما سيحدث الفرق على المدى الطويل. لدينا أغلبية ولله الحمد بما أننا مجتمع شاب، ومعظم الناس يعني لا يزالون يعني سليمين من هذه الأمراض المؤثرة على جودة الحياة. فبدل أن نركز على اكتشاف المصابين يجب أن نركز على منع الإصابة أصلاً قبل أن تحدث، وهذا ممكن وهذا قابل للعمل، وهذا هو الاتجاه السليم في الحفاظ على صحة الإنسان. الإنسان إذا عرف كيف يحافظ على صحته يستطيع أن يكون هو طبيب نفسه، يستطيع أن يكون هو الفاعل الأكبر في ذلك. لذلك مفهوم امتلك صحتك، كيف أن الإنسان يستطيع عن طريق الأدوات التقنية أن يعرف ماذا عليه، أن يعرف ما هي الأشياء التي يجب أن يقيسها باستمرار، متى يجب أن يجري الفحص الدوري، ما هو مستوى النشاط البدني الذي يجب أن يستمر عليه بشكل يومي، ما هي الأغذية التي يجب أن يركز عليها، وما هي الأغذية التي يجب أن يمتنع عنها. كل هذه الأشياء ممكن أن تكون بمتناول اليد للجميع، ولكن الوصول لها أو كيفية الوصول لها بشكل مستمر، كيفية الاستبصار بالمعلومات هو ما سيحدث الفرق في النهاية. هناك طبعا مثل ما تلاحظون هناك كم هائل من المعلومات المضللة التي أثرت بشكل مباشر على صحة الناس عن طريق التركيز على أشياء لا فائدة لها، بل أشياء قد تكون مضرة. نسمع باستمرار عن موضوع المكملات الغذائية، نسمع باستمرار عن موضوع أدوية تحسين الشهية أو تقليل الشهية، نسمع باستمرار عن أدوية يعني مثلا أدوية التي صممت أصلا للسكري ولموضوع علاج السمنة المفرطة، تستخدم في خارج السياق وتستدعي المضاعفات، وتستدعي أيضا حرمان من يحتاجون هذه الأدوية من هذه الأدوية التي تستخدم في غير مكانها. كل هذه المعلومات من السهل التأثير عليها إذا وجد استبصار بها على مستوى الممارسين الصحيين، على مستوى الحكومة، ثم نقل هذا الاستبصار إلى الإنسان المواطن والمقيم في البلد. لدينا أنظمة صحية واجتماعية هي الأعلى رقمنة في العالم. يعني المملكة العربية السعودية تصنف من أعلى الدول في مستوى رقمنة المعلومات ووجودها على مستوى وطني، لكن لا تزال بيانات خام، لا تزال بيانات يعني الاستفادة منها محدودة. فاستثمار هذه الرقمنة نعتقد أنه كنز وممكن قوي جدا لجعل الإنسان يمتلك صحته ومعرفة ماذا يجب عليه أن يفعل. لدينا تجربة رائدة في جائحة كوفيد بكيفية استخدام التقنيات في تعزيز صحة الإنسان، وهناك توجه قوي في الحكومة للاستفادة واستمرار الاستفادة من هذه التقنيات ومن هذه التجارب الناجحة في كوفيد بطريقة تلائم وضع المجتمع، وأيضا تضمن الاستمرارية وحسن استثمار الموارد. أحد أهم الوسائل لتأطير العمل والإشراك جميع من له دور في الحفاظ على صحة المواطن هو برنامج المدن الصحية. برنامج المدن الصحية برنامج له أكثر من 30 عام في المملكة العربية السعودية. المملكة العربية السعودية هي أكثر دول إقليم شرق المتوسط وشمال أفريقيا تبنيا لهذا النموذج. لدينا أكثر من 16 مدينة صحية على مستوى المملكة، أولاها تم اعتماده في عام 2014 وآخرها كان الشهر الماضي في إحدى المحافظات في منطقة جيزان. وحائل بإذن الله سوف يكون التقييم النهائي لها كمدينة صحية في نهاية شهر ديسمبر هذا العام، وبإذن الله تضاف وتصبح هي المدينة 17 على مستوى المملكة التي تدخل تحت مظلة المدن الصحية. وهناك أيضا محافظتين في منطقة حائل سوف تدخل في التقييم المبدئي إن شاء الله في بداية عام 26. هذا البرنامج برنامج رائد. لماذا؟ لأنه ينظر إلى كل العوامل التي تؤثر على صحة الإنسان ويفعل كل التداخلات على مستوى المجتمع بقيادة الحاكم الإداري في المنطقة، أصحاب السمو الملكي وأصحاب السمو الحكام الإداريين في المناطق هم من يقود العمل، هم من يشرف عليه وهم من يسعى على الحفاظ عليه، وبالتالي هم جزء لا يتجزأ في قيادة هذا العمل، وفي النهاية هم من يعني يتوج باسم المنطقة كمدينة صحية. لدينا الآن أكثر من 9 مليون إنسان يعيشون تحت هذه المظلة، ونطمح إن شاء الله للوصول إلى 15 مليون في 2030. هناك 80 معيار نستطيع أن نقول أن هذه المدينة صحية، معظمها معايير خارج المنظومة الصحية، معايير بيئية، معايير سلوكية، تعنى بكل النواحي. لعل من أهمها هو تعديل البيئة، تمكين المدينة لتصبح قابلة للمشي، قابلة للنشاط البدني، زيادة المساحات الخضراء، زيادة الوصول إلى هذه المساحات الخضراء. صحيح أن هناك 26 معيار فرعي معني بالخدمات الصحية، لكن لا يتحدث عن ماذا يحدث داخل المستشفيات، يتحدث عن كيف يصل الإنسان إلى الرعاية، والرعاية الوقائية هي من أهم هذه المكونات. أيضا دعم الأسر منخفضة الدخل من أحد أهم العوامل لتكون المدينة صحية، دعم المشاريع الصغيرة، تنمية المهارات وبناء القدرات. هناك جوانب أيضا تختص بالتعليم، خاصة التعليم المبكر. لدينا هنا بالمملكة العربية السعودية نوعا ما فجوة في التعليم ما قبل الابتدائي، وهي من أحد أهم ممكنات الصحة. فلذلك الجانب التعليمي ممثلا بإدارات التعليم في المناطق وفي المدن التي تكون تحت الاعتماد هم من يعمل على إغلاق هذه الفجوات. فهذه المعايير هي يعني يجب الاستيفاء، يعني أن تكون مستوفاة لتكون المدينة صحية، وبالعادة تأخذ عملية استيفاء المعايير ما بين 1.5 سنة إلى 2 سنين، وعندما تصبح المدينة معتمدة تبقى معتمدة لمدة 2 عام ثم تعاد تطبيق هذه المعايير على مستوى المدينة. رأينا أثر كبير جدا للمدن التي استطاعت الحصول على الاعتماد، والمدن التي فعلا كان هناك يعني تنسيق وقيادة من الحاكم الإداري استمرت في يعني استيفاء شروط المدن الصحية، كان لها أثر مباشر على معدلات الأمراض وعلى المخرجات الصحية التي يعني وصلوا لها في هذه المدن. وبإذن الله نصل إلى مستهدفات هذه المدن ونقل الموضوع من فقط تطبيق معايير إلى أن هذه المعايير كيف أثرت على المخرجات الصحية وحافظت على صحة الإنسان وأغلقت الفجوة الحادية في موضوع العمر الصحي. هذا ما وددت مشاركته معكم اليوم، ونعتذر على الإطالة، ولكن موضوع نمط الحياة وربطه بملفات الصحة السكانية نعتقد أنه من أهم روافد الاستمرارية ومن أهم روافد إغلاق فجوة العمر الصحي في المملكة العربية السعودية. شكرا لكم والسلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Abdullah Asiri, for your insightful contribution and tremendous value you added to this session. Now, I would like to introduce Dr. Jalal Awaisi, President of the Saudi Red Crescent Authority, leader whose service and impact are truly inspiring. Please welcome.
ايوه تمام يعطيك العافيه. السلام عليكم، صباحكم الله بالخير جميعا. ربط الطوارئ بنمط الحياه. وجدت صعوبه في البدايه، لكن احد المحاور اللي تكلموا فيها الزملاء، الستريس مانجمنت، هو جزء من نمط الحياه. جزء من نمط الحياه. ترى شكلها النظاره يحتاج لها الحين مع القراءه شوي. الناس تعرف الإسعاف من صوت السايرن، لكن حقيقة اللحظات الحرجة تبدأ قبل أن يسمع أحد أي صوت. هناك في موقع الحادث يوجد شخص يعيش أصعب لحظات حياته، يحاول أن يتحكم في نبرة صوته، وبين ارتباكه يبحث عن فرصة وطريقة لحفظ روح من يحب. في ال8 دقائق الأولى وقبل وصول سيارة الإسعاف، أنتم من يحدد شكل الموقف. فإما أن تكون دقائق طمأنينة يتحول فيها الخوف إلى فعل، أو دقائق عجز نفقد فيها أرواح من يحب. نحن هنا اليوم لنعيد تعريف قيمة الدقائق الأولى، ونبني نمط حياة يصنع الفارق عندما تختبر إنسانيتنا. Because in the first 8 minutes, every second becomes a second chance. The hero of our story today is Salma. Salma is not an actor. Salma is a sister calling 997 for a real call when her brother had a cardiac arrest. I want you to focus to this brief real call and listen to the tone of panic in her voice. Dispatcher telling Salma, I am here. Help is coming. Listen to me carefully. All this reassurance word was not enough for her to get confident, and we keep hearing the fear voice louder than even the siren. The ambulance will arrive in 8 minutes, but Salma in the panic mood. Not because the ambulance is late, 8 minutes is short, but because Salma never trained to be alone in that critical moment. Salma never take a training for CPR. Like most of other people, and maybe some of them with us in this room today. But unfortunately, without any option, the first 8 minutes, it belonged now to Salma. And it can belong to many of us and many family like Salma. And the problem is this 8 minutes, it could pause the life or let it continue. Why this is 8 minutes is important? It is the golden minute. And science said that every minute without CPR reduce the survival chance by 10%. So 10 minutes could be enough to take a life, or 8 minutes with action, it can restore one. And this is universal, everywhere in the world. Lifestyle is not how we live. It is how we respond when life suddenly changes. ونمط الحياة لا يقاس بعدد الخطوات فقط، بل يقاس بالشجاعة على اتخاذ خطوة حين تتغير الحياة. لن نستطيع إيقاف جميع الطوارئ والأزمات، لكننا قادرين على أن نجعل ال8 دقائق الأولى آمنة دائما. التدريب ليس توجيها يكتب، بل قرارا يمارس قبل أن يطلب. صورة معالي وزير الصحة وهو يتدرب على الإسعافات الأولية وعلى مهارة الإنعاش القلب الرئوي هي رسالة إلى المجتمع أن الجاهزية سلوك يبدأ من القيادة ليتحول إلى ثقافة في وطن لا ينتظر الطوارئ بل يستعد لها. لذلك في هيئة الهلال الأحمر السعودي we work in 2 main streams. The first stream, we introduce course called First 8 from the first 8 minutes. This course teaching 4 life-saving skills only in 90 minutes. This course directed not to the professional, it is directed to the public, to people like Salma. And we are aiming to make it for every nation and for every home. It's focusing mainly on 4 major skills, which is the time-sensitive intervention you need in emergency that need to be started in the first minute, which is including the cardiopulmonary resuscitation, using the AED, dealing with airway obstruction, the choking, and stop the bleeding. And if intervention is started in the first minute with these 4 skills when it is needed, it's going to shape the first 8 minutes into action instead of panic, and it empowers people to become a first responder instead of being witness to the panic. The second stream we work on, imagine when there is a call to 997, the technology alerting the neighbor trained personnel to respond even before the ambulance. This is not a dream. This is existing application called Al-Mustajib, which is recruiting a group of volunteers who had a training on the first 8 for an emergency nearby to respond before the ambulance arrives. And this video is going to explain a bit about more of the Al-Mustajib application.
أحد المستجيبين بإنقاذ مريض في مقهى بعد أن تعرض لتوقف مفاجئ في القلب. لم يتردد بل تحرك فورا لأنه كان يحمل في هاتفه تطبيق المستجيب. في لحظات الطوارئ لا وقت للتردد، كل ثانية قد تنقذ حياة. كن من يصنع الفرق. حمل تطبيق المستجيب الآن وكن أول من يستجيب.
You lost the connection. Yeah. المستجيب application, it's already launched a few months ago by His Excellency the Minister of Health. Number of first responders, and this application is introduced in Riyadh and Mecca now. Number of first responder applied is more than 30,000, but we are aiming is really to have millions of the first responder. The application built on a smart way. So you put yourself electively on a standby mode, and that will appear in the dispatcher room. We have a first responder using Al-Mustajib in this room. And if emergency happen, we send a request to the Mustajib, and he accepting the case, and then he will have through Google Map where is the case is. This application built on a gamification part. So it counting how many hours you get to stand by, how many cases you respond to, how many lives you save. And we're gonna start ranking that on a national level in Saudi Arabia. So the aim, technology does not replace EMS. It extends the EMS into the hand of the community. نرجع لسلمى. سلمى ولحسن الحظ أننا نتحدث في حائل. جبل سلمى هو رمز للصمود والعزة والقوة في حائل والمملكة العربية السعودية. بطلتنا سلمى لم تحصل على تدريب على الإسعافات الأولية، لكنها في موقف حاسم وحازم أمام روح أخوها المتوقف قلبه. المرحل الطبي أشواق أعطتها توجيهات لعمل الإسعافات الأولية في وقت هي غير قادرة على التعلم. فإذا استطاعت سلمى أن تحفظ روح أخوها وتعلمت على الإنعاش القلبي في أصعب لحظة لا يمكن تعلمها، فما هو عذرنا نحن في ألا نكون مثل سلمى وأن يصبح هذا هو نمط حياتنا القادم. نشوف سلمى وقصتها في حفظ أخوها حمد.
ألو إسعاف، عندنا حالة طارئة، عند أخوي الصغير فجأة أغمى عليه وما عاد يتنفس.
أشواق مرحل طبي يعمل في هيئة الهلال الأحمر السعودي، حرصت أن لا تترك سلمى وحيدة أمام روح أخوها في انتظار الإسعاف لمدة 8 دقائق، وأعطتها توجيهات حفظت روح أخوها. والحمد لله لدينا كثير من أشواق وهم حريصين على حفظ أرواحكم إذا تواصلتم بهم. But we believe if we are prepared by trained on the first aid, we're going to reduce the fear. And second part, we work on the connection through Al-Mustajib. We're going to replace the anxiety could happen in the community. Imagine a world where every family and every neighbor, every friend has the skill Selma used. Imagine every school teach the first aid, and every workplace dedicating 90 minutes a year for a life saving. This is not a health policy. This is the lifestyle we want to use and train on in the future. أتوقع إحنا ما هو تبعنا ترى، هذا خارج النص. بين اتصال ووصول الإسعاف 8 دقائق، إما أن تكون دقائق خوف وعجز أو دقائق طمأنينة وأمان. في الهلال الأحمر نسعى أن لا يقف أحد عاجز أمام روح من يحب. سجلوا في متأهب وتدربوا على 8 الأولى لنفخر بكم حينما تضيء أسماءكم غرف الترحيل الطبي كمستجيبين اختاروا أن يمنحوا الحياة فرصة لا أن يكونوا شهوداً على الألم. شكراً لكم.
Thank you, Dr. Jalal, for your visionary leadership and inspiring perspective you shared with us today. Please join me in welcoming Dr. Shayma Abdel-Al from College of Medicine, King Abdulaziz University, an exceptional academic voice dedicated to advancing medical education and community well-being. Please welcome.
بسم الله الرحمن الرحيم، والصلاة والسلام على نبينا محمد وآله وصحبه أجمعين. أصحاب السعادة، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. يشرفني أن أكون بينكم اليوم ممثلة لجامعة الملك عبد العزيز، الجامعة التي تحمل إرثاً وطنياً راسخاً في التعليم الطبي والبحث العلمي وخدمة المجتمع. ويأتي حضورنا اليوم استمراراً لدور الجامعة في دعم الجهود الوطنية الرامية لتعزيز الصحة العامة والوقاية، وانسجاماً مع مستهدفات رؤية المملكة 2030 التي جعلت الوقاية وجودة الحياة من أهم أولوياتها. الحضور الكرام، إن التحول نحو الرعاية الوقائية ضرورة علمية ومجتمعية واقتصادية، فالجامعة تؤمن بأن مستقبل الرعاية الصحية يعتمد على نهج متكامل ويجمع بين التعليم والبحث والرعاية تحت مظلة طب نمط الحياة. ولذلك تبنت الجامعة من خلال كلياتها والمراكز البحثية والمستشفيات الجامعية منظومة شاملة تعزز الوقاية ونمط الحياة الصحي. أولاً، التعليم الطبي، فعلى مستوى التعليم الطبي تضمنت مناهج كلياتها الست مقررات متقدمة في الصحة العامة ونمط الحياة والطب الوقائي، إضافة إلى برامج الدراسات العليا في الوبائيات والصحة العامة والإحصاء الحيوي وصحة المجتمع، وقد أسهمت هذه البرامج في تخريج كوادر وطنية تعمل اليوم في وزارة الصحة وهيئاتها، وتشكل جزءاً مهماً من منظومتها الوقائية. ثانياً، البحث العلمي. أما على مستوى البحث العلمي فتواصل جامعة الملك عبد العزيز عبر مركز الملك فهد للبحوث الطبية منذ تأسيسه عام 1980 دورها المحوري في أبحاث الأمراض المزمنة والسمنة والسكري والعوامل المرتبطة بنمط الحياة. يضم المركز وحدة التغذية ونمط الحياة التي تدعم تطوير برامج وقائية وطنية مبنية على الأدلة العلمية. وإلى جانب ذلك تحتضن الجامعة مراكز تميز بحثية متعددة، منها في علوم الجينوم والطب الشخصي، تسهم في تعزيز مفهوم الوقاية الدقيقة وربط العوامل الوراثية بنمط الحياة لتطوير استراتيجيات صحية مخصصة لكل فرد. ثالثاً، الرعاية الصحية والخدمة المجتمعية. وعلى مستوى الرعاية والصحة والخدمة المجتمعية تقود الجامعة من خلال مركز تعزيز الصحة مبادرة الجامعة المعززة للصحة النفسية، التي تهدف إلى تعزيز الرفاه النفسي والبدني داخل البيئة الجامعية. وفي السياق نفسه تنفذ المستشفى الجامعي عبر وحدة التثقيف الصحي عشرات الحملات الوطنية في الوقاية والصحة السلوكية والسمنة والأمراض المزمنة وصحة الأسرة ضمن دورها في رفع الوعي الصحي للمجتمع. وأطلقت المستشفى الجامعي وحدة السمنة ونمط الحياة الصحي، وهي وحدة متخصصة تقدم برنامجاً طبياً وتثقيفياً شاملاً يهدف إلى تحسين الصحة العامة ومكافحة السمنة. كما تطلع وحدة الطب الوقائي بدور أساسي في تعزيز الصحة الوقائية داخل المنظومة الصحية للجامعة من خلال برنامج صحة الموظفين وبرنامج الزيارات الوقائية الميدانية، إضافة إلى مشاركتها المستمرة في خدمة المجتمع. رابعاً، الجهود الميدانية. العيادات المتنقلة. وتعد العيادات المتنقلة من أبرز مبادرات خدمة المجتمع في الجامعة، إذ نفذت كلية طب الأسنان ومستشفى الأسنان الجامعي سلسلة من الزيارات الميدانية إلى السجون والمراكز التأهيلية والقرى، وقدمت أكثر من 1200 خدمة علاجية وتوعوية خلال عام واحد تشمل الفحص والعلاج والتوعية. كما شاركت كلية الطب والمستشفى الجامعي في تقديم خدمات وقائية مماثلة شملت الكشف الأولي وقياس العلامات الحيوية وتقييم عوامل الخطورة والتوعية الصحية والاستشارات الوقائية. ويعكس هذا العمل الجماعي بين كليات الجامعة الصحية الالتزام الجامعي بدورها الوطني في تعزيز الوقاية والصحة العامة. وتعزز الجامعة هذه الجهود عبر أكثر من 28 شراكة وطنية مع وزارة الصحة والهيئات الحكومية والقطاعات التعليمية والمنظمات الخيرية، بما ينسجم مع نموذج الرعاية الصحية الجديد الذي يضع الوقاية ونمط الحياة وجودة الحياة في مقدمة الأولويات. الحضور الكريم، إن التحديات الصحية التي نواجهها اليوم من الأمراض المزمنة إلى السمنة وأنماط الحياة غير الصحية تتطلب عملاً وطنياً موحداً وفريقاً متكاملاً يسعى إلى بناء جيل يتمتع بحياة أطول وجودة حياة أعلى. ويشكل مؤتمر طب نمط الحياة محطة مهمة لتبادل التجارب العالمية واستعراض أفضل الممارسات وربطها باحتياجاتنا الوطنية. وفي هذه المناسبة أتقدم بخالص الشكر لفرع وزارة الصحة في منطقة حائل وللمنظمين ولجنة المؤتمر على حسن التنظيم وكرم الضيافة. كما أؤكد استعداد جامعة الملك عبد العزيز بكوادرها الأكاديمية وبحثها العلمي ومراكزها العلمية لدعم أي مبادرة تعزز طب نمط الحياة وترفع جودة حياة الإنسان في وطننا الغالي. ختاماً، نسأل الله أن يجعل هذا المؤتمر خطوة جديدة نحو مجتمع أكثر صحة، أطول عمراً وأعلى وعياً. والسلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Shaima, for your enlightening contribution and meaningful perspective you brought to us today. Thank you.
نستأذن سعادة مدير عام فرع وزارة الصحة منطقة حائل للحضور على الستيج لتكريم فقرة التكريم. Thank you all. We're finishing our keynote speech, and now we're going to honoring part for the speaker. Please. Our finished honoring to Dr. Abdullah Asiri for the very nice talk and contribution in the keynote speech. Next honoring to Dr. Jalal Al-Waisi. And Dr. Shaima Abdulaziz Abdelal, come please. Thank you. Now we reach the end of our first session on the soft opening of the scientific committee. Thank you. In a few moments, we'll start the second session, inshallah, with the other speaker. Just a few minutes. Thank you.
If medical school taught lifestyle habits first, half of us wouldn't have survived this semester.
True. Imagine graduating knowing how to sleep, eat well, and manage stress. It will be revolutionary.
Then what habit do you think should be mandatory in medical education?
We will dive into that with our next session moderator, Dr. Michel Anais, Scientific Committee Chairman, Consultant in Clinic Pharmacy and Internal Medicine Pharmacotherapy. Welcome, Dr. Michel.
Again, good morning, everybody. Welcome in حائل. Assalamu alaikum wa rahmatullahi wa barakatuh. I will moderating this second session. The second session talk about the lifestyle medicine, reshaping medical education and future health system. Our first speaker, the Professor Salman Rawaf, he is the Chair of Public Health, Director of the WHO Collaborating Center, and Head of the Center for Health System Development in the Department of Primary Care and Public Health. Please welcome with us Professor Salman Rawaf.
Bismillah ar-Rahman ar-Rahim. Good morning, everyone. I'm delighted to be here again in Ha'il in this beautiful conference. I'm really most grateful to my dear brother, Dr. Mishal, and my sister, Dr. Marwa, and all my colleagues for the kind invitation. I mean, today I'm taking you through some experience in many other countries around the world where they actually moving the whole health systems in totally different directions because of the health crisis we have now. And I will share with you this in a minute around the world. Let me, can I get the slide? Yes, started moving. Okay. It's a bit slow. I don't know where I directed.
We'll try the red one.
Which one?
The red one, maybe it will.
The red one?
Yeah.
Press the red one?
Yeah, forward.
Okay. Okay. That's the one. Thank you. I think the first question when we talk about prevention, the whole idea is we're talking, Shaima mentioned the issue how King Abdulaziz is actually moving the prevention agenda. Most of the countries around the world realize that this is what is missing in the health systems, okay? So lifestyle medicine is a small part of prevention agenda, they're huge, but it is a key part, it's a very important part. We highlight this, how lifestyle medicine is shaping our life. The key question we must ask, why are some people healthy, others are not? I mean, this is not a philosophical question. I mean, as director of public health for many, many years, I always ask why we have proportion X percentage of my population are not healthy. And this is really the answer which we need to find. You know, look what we have today. The more we have research, innovation, discoveries, the more we discover that medicine is limited. It's really limited in dealing with people's health problems. Escalating cost of healthcare, every country in the world. I challenge anyone who can say that this is not the case. Every single country, even the best health systems in the world, among the top 20s, They have major problem with accessing health services. I can't tell you catalog of stories about that. Chronic diseases now dominating our life everywhere in the world, when 71% of the death are due to chronic diseases. Aging population, Japan population, for example, 30% are over the age of 65, and more to come. We know about health inequalities, increasing health poverty. A lot of people are not able to pay for a treatment, which are very costly. Let us look at health system crisis. Even in United Kingdom, when we have 7 million people waiting for health care, one of the top rich countries, fifth rich country. And if you look, hospitals and primary care network are overstretched. We know overstretched because people demanding more and more, simply because of the knowledge they have, social media, television, radio, etc. We have shortage of health workers. Around the world, it's estimated between 12 to 20 million, it depends, of doctors are missing. We need more, you know? And the fragmentation of health systems. I mean, even in this country, you have about 13, 14 providers of healthcare, they don't talk to each other. So we have real problem. We have real problem within our health system. So look at the Kingdom of Saudi Arabia. And I don't want to go into this data is not published. This is for, you see it for the first time, okay? And I'm sharing you for the first time, and I'll go a little bit of analysis. If you look the blue, this is all metabolic disorder, whether it's kidney, or whether it is heart, whether it's a stroke, etc. All these are almost 80% of these are preventable. The question is, why don't we prevent it? Again, look at the kingdom. This is 2003, the most updated data, which we brought it to you. Look at the risk factors. And the blue here is metabolic. This is all coronary heart diseases, stroke, etc. And all linked to the common high risk factors which we can prevent through changing people's lifestyle. So we have here opportunity. We are missing a great opportunity. Again, we look more into the kingdom data and the change between 2000, this is 23 years alone. Look at this, from the low birth problem into high body mass index and diabetes. Two conditions which we can prevent, yet we are not preventing. The question which I'm asking everyone in this hall, we were talking about it. I mean, I gave a talk about this one in the Kingdom of Saudi Arabia 20 years ago. And everyone say, we are dealing it, we are doing it. In reality, it's going up and up and up. So who is responsible for the failure? Who is responsible for the failure? So this is the question everyone sitting here must answer it. And again, this is not Saudi Arabia, but almost all the countries in the region, even the advanced countries like United States and Japan. Look at Kuwait, Jordan, Iraq, Egypt, United States and Japan. All they have similar problem in terms of going up, at least some of them a little bit steadier than others. Let us see why lifestyle medicine could be the driver for change. The last few slides with you I want to share. We estimated through WHO that 70% of the global burden of diseases are due to chronic diseases which are preventable. That 80% of coronary heart diseases and diabetes and 40% of cancer can be prevented. These are big figures. When we say can prevent it, it's beautifully to say it. The question is how? Are people willing? Let me say to Shayma, The problem is with our medical school. As a president of the International Association of Medical Colleges around the world, I say to medical school, the problem is you, the medical school around the world. You are not preparing doctors to maintain our health. Unless you change, we will hold you to account. The people will hold you to account. So let me repeat this. And I would say the problem we have today, we know the solution, but medical schools are not taking this seriously. And I want anyone from any medical school, anywhere in the world, come and challenge me. Look at this, the nice guideline saying that now the first therapy is changing lifestyle. And it's very important that we that taken seriously. And we can actually prolong life through lifestyle medicine. And many colleagues today, tomorrow, and after tomorrow will produce and share with us fantastic evidence. And it's time we take it seriously and we take action, not just observing it and taking note. And let's look, the core component of these, actually we call lifestyle medicine, is the agenda for population health management. And I'm delighted the Kingdom of Saudi Arabia is leading in the world with population health management. The National Guard, the Ministry of Health, taking the lead in population health management. And we have opportunity because these will improve the outcome for high-risk population, reducing admission to hospital, which is very costly, and improve the quality of life, which is the important target. All of us, without any exception, looking for it. I want a good quality of life. You want good quality of life. So why don't we have it to everyone in our community, in our society, in our country, in our world? We have to have a world, a healthier world. Let me give you a couple of examples. Very briefly, a few months I was in China, looking at the beautiful way they are integrating lifestyle medicine into their health system. The Chinese moving at a speed which is absolutely unbelievable.
5 minutes.
I'm about to finish. And the second example is Singapore, New Zealand, even United States is moving in that direction. These are the agenda for you. You're welcome to all the slides. And look at the shift from, we are reacting from the shift, redesigning primary care, the way we're financing, and integrating digital tool into the way we are operating and preventing diseases. All these are based on research. When people talking about research, it's not for the sake of research. How to make research applicable? This is our team. Sunil, one of them, Muhammad, one of them, Sana. Delighted they are here with us. These are the work which we do to integrate lifestyle medicine into the reality of the world. And again, this is how medical education should be in the future. This is by itself need a lecture. I will not spend time. It's a beautiful article, 2 articles in the Lancet and BMJ, talking about how we shift medical education to prepare a new generation of doctors who can and able to look after our health. And my key messages at the end, I leave you with these for you to read it. And lifestyle medicine can change our life, can make us healthier, can make us live longer. And I thank you very much indeed for allowing me to talk to you today. Thank you.
Thank you, Professor Salman, for this nice talk. Our next speaker is Miss Kelly Freeman. Kelly Freeman is the current director of the workforce development of the American College of Lifestyle Medicine. Please welcome with us Miss Kelly Freeman. Thank you. Thank you. You can try this red button for the forward.
All right. Hello, everyone. My name is Kelly Freeman. I'm grateful to be here with all of you. I'm from the American College of Lifestyle Medicine. I live in Indiana in the United States. And now we're going to talk about some tools and resources that are available for all of you. But first, I want to share just a little more about the American College of Lifestyle Medicine. So our mission statement is up on the screen here. We are trying to advance evidence-based lifestyle medicine to treat, reverse, and prevent chronic disease. And we have a vision that globally lifestyle medicine will be the foundation of health. So it's so wonderful to hear the World Health Organization and so many of you talking about lifestyle medicine, because certainly in order to make the changes that we need to make in order for a healthier population, we need lifestyle medicine to be the foundation. Oops. Okay, there we go. So lifestyle medicine is interdisciplinary. Of course, we have our physicians, and then we also have our nurses and occupational therapists and physical therapists and pharmacists and everyone working together to move our patients' health to the optimal level possible. And so teamwork does make the dream work. And so the American College of Lifestyle Medicine has tools and resources basically for physicians and clinicians, the entire healthcare team, as well as those who teach in medical schools and in nursing schools, all of the interdisciplinary healthcare specialty programs. And then finally, we have tools and resources available for your patients. And so let's first talk about what's available for you, the healthcare team. First of all, we have a variety of handouts that you are welcome to download from our website. Our website is lifestylemedicine.org, and we welcome you to translate these if you need to. We would be honored for you to do so. We have assessment tools. I want to mention that there is a short and a long lifestyle medicine assessment form. In order to know what our patient's lifestyle is like, we first must do an assessment. We can't assume what their dietary pattern is, what their level of physical activity is, how much sleep they're getting, how much stress they're under, how much they're sleeping, etc. We have worked with health systems and clinics across the United States to put together implementation briefs. These briefly describe how lifestyle medicine has been moved into clinical practice to give you all examples that you can utilize within your own work. And I want to point out, especially the work that's being done in San Diego, UCSD, their resources are available for you to download and use in your clinic. So I'll share a little bit more about that in a moment. Great. And then we do offer webinars every month. And please, if you go to our website, lifestylemedicine.org, you can sign up and find out when our webinars are and join us for these. Our members, who are experts in lifestyle medicine in a variety of medical specialties, have worked together to create toolkits. Our newest one is on menopause, but we also have many others that can be utilized. We have shared medical appointments resources. So what we're finding is that in the United States, we are offering more and more shared appointments. And as was just discussed earlier, we don't have enough physicians. We don't have enough healthcare workers to accommodate the needs of all of our patients. So if we can have our patients to come together in a shared medical appointment, it is a wonderful way to deliver lifestyle medicine. And there are multiple tools and resources available for you to use. And these are just a few more examples of this. For example, Full Plate Living from Ardmore Institute of Health is all about eating the healthiest dietary pattern in order to improve health outcomes. The SLIM program from UCSD is all about weight management. And then finally, the American College of Lifestyle Medicine has the LEADER program, which is all about diabetes remission. And Jessica Jolly will be on stage next to talk a little bit more about tools and resources for diabetes remission specifically. As far as faculty in universities and professors, we do have resources for you as well. And so I wanted to highlight these. The first is called, And let me go back for 1 second and share with you that my main role at the American College of Lifestyle Medicine is working with faculty across the country to move this content into their curriculum. And this is a list of all the universities that I'm currently working with. And I would be honored to spend time with any of you that are teaching. And so we can discuss in more detail how this, you may be able to move lifestyle content into your program as well. All right. Okay. We base what we are teaching within our programs on the 2022 Lifestyle Medicine Core Competencies. These are 88 core competencies in lifestyle medicine, and this is a published article that you can download and read. And then more recently, we did have an update to this. So there are just some minor updates that have been done in 2025, and they are listed right here. So social determinants of health, learning about social determinants of health, addressing those is listed in the core competencies now. All right, so one of the resources I wanted to mention is Lifestyle Medicine 101, and it is 13 slide decks regarding health behaviors and health coaching and motivational interviewing and basics of lifestyle medicine. So you are able to download this resource. And one of our newest resources is the culinary medicine curriculum. This is from Dr. Michelle Hauser at Stanford University in California. And basically it is over 400 pages of curriculum that you can utilize in your courses. And alongside that are videos, over 15 hours of video content. It's short culinary medicine videos that you can use, that you can share with your patients, and that you can share with your students. So this is all available for you for free, complimentary from our website. And then also we work very closely with the LMED, so lifestylemedicineeducation.org, to offer a variety of resources on specific medical topics, diseases, and conditions. And so if you go to this open educational resource, lifestylemedicineeducation.org, you can click on curriculum and download a number of different slide decks, case studies, and presentations. There are also a number of books that are available, textbooks. In fact, we have some authors here in the audience, so explore all of the different opportunities for you to share these types of textbooks with your students. And with all three of these that are shown here, if you are faculty, you can request a complimentary desk copy. All right, and so next, let's explore some tools and resources for your patients. All right, and for an example, we're going to look at older adults because aging is such an important part of this this conference. And so I want to ask you something, and just something for you to think about. How do our older adults tolerate procedures and medications and surgeries? And sometimes they can do well, but we also know that sometimes we need to protect our patients from extra medications and surgeries that they may not need if we can instead move to lifestyle interventions. So in 2019, one of our members, Dr. Susan Friedman from New York, had published an article, a white paper on healthy aging. And I would encourage all of you to download it if you're interested in this topic, because it gives a wonderful foundation of how lifestyle medicine works so well with older adults.
5 minutes.
Thank you. Right. And then in the United States, there's been more and more focus on age-friendly care. Now, age-friendly care has 5 components, and those are a focus on medications. How many medications are our patients taking? Are those medications safe? Are they effective? Do the patients need the medications? And then the mind, how well is their mind working? Is there any cognitive decline? How can we optimize the brain health? Mobility, how much physical activity is possible with this patient? Are there ways that we can optimize physical activity? Multi-complexity looks at all the different situations and diagnoses that we're dealing with our older patients. And then finally, what matters most? And that's not what matters to you and I as healthcare professionals, as physicians. It's what matters most to our patient. That is primary. And as you can probably imagine, age-friendly care and lifestyle medicine fit hand in hand. Very, very important that these two work together. So in summary, lifestyle medicine is cost-effective. It is safe, it's evidence-based, it's person-centered, what matters most to our patients. It's goal-directed, high value, meaning it doesn't cost a lot, but the benefits are multiple. And within moving more lifestyle medicine into the care of our older adults and geriatrics population, there's the opportunity to prevent falls, to prevent frailty, and for them to live healthier, longer lives. So this can be very satisfying, not only to our patients, but for the caregivers and for healthcare professionals. I wanted to just list a table of other resources that are available for you if you want to take a screenshot, or I'm happy to share my slides. But these are all assessment tools specific to older adults. So I will just scroll through these slides here. And you can see how the slides listed on, the table here lists all of the 5 M's and what different tools you can use to assess your patients. And then here are some specific questions that you may want to ask your patient that relate both to the 5 M's and also to lifestyle medicine. And finally, just a few more tools and resources if anyone would like to take a picture of this slide. And this QR code will take you directly to our website, to tools and resources. You may need to make a free account, but once you do, you can have access to all of the patient-centered resources, as well as attend our webinars if you would like to. And for some of those other resources that are available to our members, I do invite you all to become a member of the American College of Lifestyle Medicine if you would so like to do so. And finally, just a few more tools and resources specific to our older adults that are available to all of you. So one here on overactive bladder, constipation, a healthy brain, as well as a healthy dietary pattern. All right. So in summary, lifestyle medicine supports an interdisciplinary, patient-specific approach utilizing the tools and resources that are available. And so many of these are complementary. They're here for you to utilize. And there's so many ways that you can move this type of material into your colleges, your universities, your medical schools, and it's necessary. We need this to happen now in order to really improve the outcomes of our patients. And I would be honored to connect with any of you. I have my email listed there. Please feel free to reach out if you would like to collaborate or further discuss anything that I have mentioned today. And thank you very, very much.
Thank you, Kelly, for this nice and informative talk. Just to please, I want to announce for all of you, if you notice, we have a mini QR code in the side screen, showed when the speaker talk. So I need from you, please, all audience, to screen this QR code for three things. The first thing is for the question, we have a QR code. It will be appears during the speaking or during the lecture. One QR code for the questions, and we need your feedback and questions for the speakers. So we'll discuss these questions in the panel discussion. The other QR code for the evaluation. Evaluation everything. We put many or some few questions that evaluate the speaker, the moderator, evaluate me even, and evaluate everything around you. The third idea and the third QR code, you will see it during the lectures, that the open dialogue sessions and open dialogue offices, it will be in the other hall. We have actually 4 open dialogue, name Saudi Vision and Hatem and Ajaglow and Al Badr. This is in the break. Every speaker, that one who registered with us, he will interact with some 5-6 persons from the audience. So it will be a good chance, more connection and more interaction between the speaker and the audience. Okay, I will repeat in Arabic. إذا سمحتوا للجميع، يمكن لاحظتوا أثناء المحاضرات هناك QR كود تطلع على السايد سكرين في اليمين وفي اليسار. نحتاج منكم الله يعافيكم تسوون سكان للQR كود هذه. في QR كود خاص للأسئلة، ونحتاج منكم تسألوا أو إذا عندكم أي سؤال للسبيكر عشان نتناقش فيه في البانل ديسكشن إن شاء الله. QR كود للتقييم، نحتاج منكم أيضا الفيدباك التقييم. في عدة أسئلة تقييم للمتحدث للمودريتور، قيموني أنا أول واحد وزين مو زين عشان ما يجيبوني طب المطحات مرة ثانية. تقييم للمكان، تقييم لأي شيء. فالله يعافيكم، نحتاج منكم الفيدباك، يهمنا رأيكم، يهمنا الفيدباك منكم. QR كود الثالث إذا لاحظتوا في ألوان بنفسجي وبرتقالي وبني، هذه ألوان جلسات حوارية مع المتحدثين، وتم التسجيل فيها من المتحدثين ومن الحضور. اللي يرغب انه يجلس مع احد المتحدثين الظاهره اسمائهم في الشاشه، just scan the QR code وتسجلون، ويصير عندكم فرصه في البريك ان شاء الله انكم تجلسون مع احد المتحدثين وجها لوجه في جلسه خاصه وتسالون اسئله عن قرب. فرجاء راح تلاحظون ان شاء الله في المحاضره القادمه الكيو ار كود هذه بتطلع، فسووا لها سكان ويعني شرفونا بارائكم واسئلتكم. يعطيكم العافيه. So we'll move to our third speaker, Dr. Jessica Julie. Dr. Jessica, she's the founder and CEO of Nourish and Flourish LLC and a consulting and health coaching practice that supports organizations and individuals in achieving greater well-being and leadership effectiveness and organizational transformation. Please welcome with us Dr. Jessica Julie. Nice. Good luck. We can try this. Yeah, this for beginning one.
Good morning, everyone. Thank you so much for having me. My name is Jessica Jolly, and I'm actually the Senior Director of Practice Advancement for the American College of Lifestyle Medicine. I am also a health coach as well, but I also bring greetings from Dr. Padmaja Patel, the current president of the American College of Lifestyle Medicine. And I'm so elated to be here and excited to talk to you all today about diabetes remission in older adults, specifically embracing our new clinical practice guidelines. Okay, there we go. Got to get the clicker working. All right, so our learning objectives for this session. First, I'd like you to understand the purpose and the structure of the new guidelines that we've created. Explore the key action statements and the evidence behind them, as well as learn how to apply the clinical practice guideline in specific clinical settings for older adults. So as Kelly mentioned, there is a need to focus on older adults, and we have this specific resource for you. So Professor Solomon did an excellent job talking about the global burden of type 2 diabetes, but just to refresh our memories a bit, the type 2 diabetes has been termed the epidemic and defining disease of the 21st century, specifically due to the prevalence as well as the impact. When we think about it from a financial standpoint and an impact standpoint in terms of people, about 1.3 billion people are expected to have diabetes by 2050, with a cost of over $1 trillion. Specifically, the Saudi Ministry of Health shows that 24% of the KSA population, or about 7 million people, have type 2 diabetes. Can you raise your hand if you know someone with diabetes or pre-diabetes? Look around the room. Many people, right? And so when we also think about in the United States, 50% of the population has diabetes or pre-diabetes. So this is something that is important and needs to be addressed. But what's something that is optimistic and positive is that 80% of type 2 diabetes is preventable with lifestyle medicine. So why should we focus on older adults? We know that this particular group, the prevalence is growing, and it is becoming the fastest group with type 2 diabetes. Also, we need to think about the complications for this group. There's neuropathy, vision loss, and cardiovascular disease. And then also, lifestyle-based deprescribing may help reduce polypharmacy. And then lastly, functional limitations can be improved through targeted lifestyle medicine support. So our clinical practice guideline was actually developed because there is a need to, there was no actual clinical practice guideline that focused on lifestyle medicine as the first line approach, and we wanted to address that specific need. So our purpose was to give clinicians a specific actionable guidance that they could use in community settings as well as in healthcare settings, and it would be easy for them to follow, specifically for non-pregnant adults with type 2 diabetes, gestational diabetes, as well as pre-diabetes. And so just to level set, type 2 diabetes remission occurs when there is an A1C of less than 6.5% for at least 3 months with no surgery, no devices, or medications that lower glucose. So this particular guideline was developed in a significant way. And so we did this in a multidisciplinary approach. We had 20 different individuals and professionals participate in our group, and 13 disciplines were represented. So cardiology, endocrinology, pharmacy, health coaching, the range, and the likes. We specifically have 10 endorsements for this guideline, and that's really important because it helps with adoption, it helps with credibility, as well as support. And so when we think about the evidence behind this guideline, you can see that over 126 systematic reviews were done, as well as a number of randomized controlled trials that were reviewed. And this document is so comprehensive, there's over 120 pages in the guidelines. So when we think about the recommendations, they were actually determined based off of the Oxford Center for Evidence-Based Medicine, the framework. And so each of the recommendations was given a grade ranging from A through X based off of the evidence for treatment, harm, diagnosis, and prognosis. And so grade A, grade A is the gold standard where systematic reviews were pretty prevalent. And then all of our recommendations were at least a grade A or B within this particular guidelines. And the recommendation strength is based off of the evidence grade as well as the preponderance of the benefit as well as the balance of benefit and harm. So that's really important. With our recommendations, everything has either a strong recommendation or a recommendation. So what are the components of our clinical practice guidelines? We have an introduction and background. We have 14 key action statements, as well as implementation resources and over 30 tables, figures, and resources. So this particular visual is probably the most important one that you'll want to take a picture of and save. This includes all of the key action statements that a clinician would want to use to walk them through the steps of helping a patient get to a point of remission. And we're going to go into that in further detail. So here is the anatomy of a key action statement. It includes the quality improvement opportunity, which is based upon the national strategy that we have in America. It also includes the strength and evidence related to that specific action, value judgments related to social constraints as well as scientific value, patient preferences, which we know are really important when you're working through these specific lifestyle interventions, as well as implementation insights. That's important for you. And so these components make up what we call an action statement profile. So here is just a quick visual of what it looks like for the 14 key action statements within the clinical practice guidelines. You can see the anatomy listed here. You see the opportunity for improvement, the strong recommendation or the strength recommendation, the evidence as well as cost, and the value judgment. So within the guidelines, you'll be able to see this for each of the 14 statements. All right, so let's look at each of them. So for the first three, these particular action statements focus on advocating for lifestyle medicine as the first line approach. It also includes assessment. So Kelly showed you a visual of our lifestyle medicine assessment. That is the second step in working with patients to get them to a point of remission. We also have establishing priorities. We know that that's important to get the patient to take steps towards remission. Okay, this is just a graphic, one of the wonderful resources that we have, but this one specifically focuses on SMART goals and getting the patient to think about what's important to them to get them to the highest vision of themselves. So when we think about older adults, we want to think about the social barriers and drivers that they may experience. Transportation and mobility may be a challenge. So how do we, as clinicians, address that proactively? That's important. As well as food insecurity. Many communities, there are food deserts, and so that must be taken into account. As well as social isolation, stress, and that may reduce program adherence. We want to take those things into consideration, as well as technology. So thinking about the next couple of interventions or key action statements, they're focused on lifestyle. And so you can see these are focused on the 6 pillars of lifestyle medicine, but there's also the addition of a focus, an action statement related to sedentary time, reducing that, as well as a goal around remission for you, creating a nutrition plan related to remission. It's important to discuss that with the patient so that they want to actually take the steps of getting to remission. So here is a table that summarizes all of the assessment tools that are available. Again, another wonderful resource within a clinical practice guideline, but it includes all the various questionnaires that a clinician may want to use when thinking about the actions that are necessary to get the patient to diabetes remission. And so here's a wonderful resource within the guideline that shows how a person can move towards a more plant-predominant eating pattern. Excuse me. All right, so within older adults, nutrition, from that perspective, there's an emphasis, or should be an emphasis, on high fiber foods to improve glycemic control, as well as address common deficiencies such as B12, vitamin D, and calcium. And then also, culture is important. We want to leverage that to make sure that the food that is being consumed is something they want to eat. And then also the support. If food is not readily available, how are they going to access that as well as prepare the meals? So from a physical activity standpoint, strength training is crucial. We know that over time, muscle mass can be lost, and so you want to take that into consideration when taking the key action statement related to physical activity into consideration. Also, daily movement is important, so you want to set a goal of increased steps and reduce sedentary time, as well as assess fall risk. For our elders, it's important that before training intensification happens, that is assessed. And then also use of assistive devices can be helpful from a safety standpoint. So some of the adaptations that are necessary for older adults include low impact exercises such as chair exercises, Tai Chi, aquatic therapy, and then nutrition. We want to think about the oral health. What needs to happen from an older adult perspective? There may need to be changes that are necessary. Also, stress reduction is important when we think about cognitive ability and limitations. You want to take that into consideration as well. And sleep. We know that with type 2 diabetes, there's often a prevalence of sleep conditions, but they may not be assessed. So that's really important for our older adults. All right, our last couple of key action statements relate to behavior change, continuity of care, and adjusting therapy. It is recommended that health coaching, motivational interviewing, and cognitive behavioral therapy be integrated when working with an individual who wants to get to a point of remission. We also want to take into account what is the plan for care? How often is that going to happen? How long is the duration? And making sure that the patients are engaged. And lastly, when we think about the adjustment of therapy, oftentimes with lifestyle interventions, there's a need to deprescribe. And so you want to do that proactively before hypoglycemia occurs or any other interactions may happen. So here's a great tool that's also in the clinical practice guideline. It's another one you may want to take a photo of. But this provides insight as to what should happen with deprescribing medication. Specifically, when there is no risk or low risk for hypoglycemia, education is really important. You may not need to change the medication, but there should be a conversation about that there may be a need to reduce medication over time. But if there's a significant risk of hypoglycemia, then you want to, again, take that proactive approach to make adjustments before hypoglycemia occurs. So thinking about older adults and medication deprescribing, it's important to achieve balance and maintain stable glucose levels. Also, close monitoring of renal function and hydration is also important, so you want to take that into consideration. Also, polypharmacy. This is a big one. When we think about lifestyle interventions, there may be a need to eliminate unnecessary medication and agents. But does the patient understand that? So you really want to take time to discuss that with the patient. And then also shared decision-making is necessary.
3 minutes.
Thank you. So in terms of unique clinical considerations, Cognitive decline is a frequent experience. And so you want to, again, take that into consideration so that we don't have prolonged hyperglycemia. Age-related sarcopenia requires prioritizing strength training, as well as a high prevalence of sleep disorders. So, enhancing success in older adults. What we have found is that use of simplified goal setting with frequent follow-ups are very helpful and will assist with getting a patient or a person to remission, as well as incorporating caregivers into lifestyle coaching. Again, I'm a health coach, and that has been very helpful for those who are in my family. And we see that that is supported with research, as well as leveraging community resources. So faith institutions, meal programs, senior centers have been critical for working with older adults trying to achieve remission. And then also supportive routines that integrate physical activity on a daily basis is important as well. So evidence supports remission for older adults. We see this with studies that show that those who are 65 and older and all ages are able to achieve it, as well as weight loss, predominant, significantly improve insulin sensitivity, and then also demonstrating better adherence to structured programs, and specifically group visits, such as Kelly mentioned earlier. So I want to, in closing, tell you about Anne. Anne, I met her, or in this particular instance, she was 66 years old. She smoked for 50 years, had a history of obesity, hypertension, type 2 diabetes, COPD, COVID-19, and significant trauma. And unfortunately, she had to have a quadruple bypass surgery on May 10th. I got engaged with her, and I was able to identify what were her main motivation, or what was her main motivation for lifestyle change. It was her family. She got into a 12-week cardiac rehab program that had group visits. She quit smoking. She also transitioned to a whole food plant-based nutrition plan. She did 30 minutes of exercise and strength training. And she also had a schedule. I created the schedule of daily activities related to sleep, meals, and exercise. And then I became her in-home health coach and caregiver. And I'm happy to report that in September of 2021, Anne achieved type 2 diabetes remission with a hemoglobin A1C of less than 5%. Now, Anne, yes, that's worth clapping for. And I'm actually excited because Anne is my mother. That was my mom. And so it's our hope. Thank you for that. That's my mom. And that's probably one of the things I'm most proud of, is that we were able to get her diabetes to a point of remission. So it is possible. And it is our hope that through this clinical practice guideline, that there'll be many more people, many more individuals who have a story like my mother, like Anne, and they'll get to that point of remission. And so with that being said, I want to say thank you. And here's the QR code to access the clinical practice guideline. We hope that you'll use it and share it widely. And there's 3 versions available: the comprehensive clinical practice guideline, an executive summary, as well as a plain language summary. So please do take advantage of this wonderful resource. It is free and available, and it provides all the steps you need. So thank you so much.
Thank you, Dr. Joseph, for the nice talk and the last story. Please, I would like to invite our speaker for the panel discussion, Professor Salman and Ms. Kelly. Please come to the stage. And if you have any questions, the floor is open for the questions, and the mic is yours, because we have some questions reaching in the link. But if you want to ask, it's open for any questions.
Questions? Come here, please. أقرب. Okay. Thank you, Professor Salman. Thank you, Ms. Killian. Thank you, Dr. Jessica, for this nice talk and informatives. Actually, this is a lovely morning that we have you in this early morning session. You mentioned very important information, again, the lifestyle medicine worldwide and your experience. Actually, I love your story, Jessica. It's very touching for all the audience even. I have questions, and maybe open the floor to the audience to ask if there is any question. My first question to Professor Salman. You mentioned on your slides that the medical schools is the problem. Maybe somebody has just catch up after that. I want you to elaborate deeply why. Excuse me this question, but I want to know why. Just elaborate on this. Excuse me. Thank you.
Thank you very much, Dr. Mishal. The issue of preparing the next generation of doctors, nurses, and other health professionals able to speak the language about people health. You see, even in the last two presentations, we were talking about patients, you know? And this is not a criticism. This is because the mindset, this is how you brought. This is how they brought us as a healers. They are not brought us actually to look at the entire population. If we want to achieve what Jessica was talking about, we have to achieve it through the healthy people. Our success is by maintaining health. Our success is not by treating. Most of the time, yes, you can treat people, healing people. As a physician, you see, in 80% of what we are dealing with, we are not achieving a cure except in infectious diseases. We are just putting people on drugs and more drugs and polydrugs. Even we are not trained to review the drugs which we give. There are so many problems. If I mention it to actually, you see, in the United States, and I have two colleagues in the United States, and I admire actually my colleagues in the United States in terms of contribution to science, advancement, and technology, etc. In the United States, 10% of death and diseases are created by doctors. 10%. And in our region is about 18%. You see? So that needs to change. We need to have paradigm shift. The problem, we don't have the teacher who are teaching the student the right things. If you look at the people in public health in medical schools, most of them, they are not practitioners. Holding a PhD degree or simply got an MPH or something like that. They are not practicing, yet they're teaching you about public health from theoretical background. So the problem is so big, but it needs to change. The change will come from you, from health authorities, because health authorities need to say, you know, this type of doctors we need, this type of nurses we need. This is how the future look like.
Thank you, Dr. Salman. I think the picture now is coming more clear, for me at least, and maybe the audience. We have questions here. Please, mic here. Rahman. Mic. No, stay, just sit. We have the guys here. Give the mic.
Thank you so much for this wonderful talk, actually, and practical talk. I'm Dr. Nisreen, family medicine and lifestyle medicine consultant, and also coach, and totally believe what all these talk today. Dr. Jessica show us promising actually module, especially for the prescription of diabetes and this chronic disease. And my question for this issue, so if I have patient improving and has A1C, according to the criteria what mentioned American Diabetic Association for reversing chronic disease, and we want to de-prescribe the medication, up to which duration we can say this patient reversible chronic disease or reversible diabetes, and what specially criteria I have to follow for follow-up for 5 years, for 1 year, for how long. So this is for diabetes remission. And the other question for Prof. Salman. Actually, you touch a very sensitive area, especially for us in working in educational hospitals. We're facing this problem with our students, with our residents, with our interns. When we talk about lifestyle intervention, at the beginning, they're introducing the cases as a disease. They're not even dealing with the patient, just looking as a disease mindset, not as a health mindset. Teaching student as reactive instead of proactive. This is, I think, our issue. And if we can start as early as possible in colleges, what the first steps we can even touch in medical schools to at least change its mindset. So I think it's only related to mindset and values for believing on such a healthy lifestyle models, especially if we have now talking about remission of chronic diseases, that in one day we was introducing a diabetes as a chronic disease, never ever cured. And this is, I think, applied for all chronic disease.
Thank you, Dr. Nasreen. I understand that first question you asked Dr. Jessica. So Dr. Jessica will, or Dr. Akili will answer the questions. No problem.
If I may, I'm going to hopefully address your question. So this is related to deprescribing with diabetes remission. And something that I want to highlight is that lifestyle interventions can be extremely effective. And so as the patient is making these lifestyle changes, we have to be very, very cautious with the medication dosages, and we must de-escalate the medications quite quickly in some situations to avoid hypoglycemia. And there's that same situation if we're working with patients with hypertension. Their antihypertensive medications may need to be de-escalated very, very rapidly so that they don't have too low blood pressure. If you look back at the history of prescribing medications, we have so many guidelines that talk about how to prescribe this medication and when, and we don't have as much information about how to deprescribe, which is what is so novel about what Jessica had discussed. There are some organizations that are working alongside the American College of Lifestyle Medicine that are specifically looking at deprescribing and also the benefits versus the risk. And I'll mention just a few of those. One is deprescribing.org, and that's out of Canada. And then there's deprescribingresearch.org out of the United States. And then there is also a website that is the NNT, the number needed to treat.com, thennt.com, which is a wonderful resource for physicians and clinicians to weigh the benefits versus the risk of numerous medications and procedures. So I hope that answered your question, but if not, you know.
Thank you, Dr. Kelly. Any addition?
Can I say something? Actually, I'll make it general. First of all, lifestyle medicine is not new. If it's nice to be brought all together. The 6 pillars and the nitty-gritty of these 6 pillars is part of our practice for generations. You know, even in our Islamic teaching, you find a lot of these elements beautifully highlighted. Having said that, you see, the problem is we need to be very careful not to commercialize lifestyle medicine. And once we actually use it as a tool for dealing with patients and making their life is better and improving the quality of life, which is a great aim, but we make it a tool, you know, just to enhance the treatment through lifestyle alone, that's very risky. And I always say to colleagues, this is extremely risky approach. You have to direct it to the total population. And we have a great opportunity. I mean, the program, when I was director of health in Southwest London for a long period of time, the program which called lifestyle approaches, we call it lifestyle. This is in the early 90s, okay? You know, the lifestyle project was about how do you live healthy life. It's a great opportunity from the day you're born. And our research actually now, you know, focusing on the first 1,000 days of life, from the day of conception to the end of the second year. حولين عامين, okay? And this 1,000 days of life is the foundation of healthy aging, which is referred to, you know. In a talk in China, I was talking about prevention of dementia. The focus is on the 1,000. So lifestyle medicine starting the day the mother conceived a child. And about healthy sleeping, healthy eating, healthy, you know, relationship, emotion, etc., etc., etc. So we need to move the agenda, and this is my aim, this is what I'm talking about, this is what I refer to, moving the agenda, simply looking at diabetic patient as hypertensive patient, as this and that.
Thank you, Dr. Salman. Questions? Still we have like 2-3 minutes for questions, so maybe one more. تفضل دكتور.
Yes, my name is Abdurrahman Qabbani. I'm an endocrinologist and certified in lifestyle medicine. My question is to Professor Rawaf. Is there any white paper or position statement that provides guidance for changing the culture or curriculum in medical schools to address the problem that you're talking about? Because we are dealing with generations that keep promoting the same knowledge, but we don't talk about disease reversibility, you know, healthy living and all that stuff. I don't remember any lecture talking about healthy living, healthy aging when I was in medical school, healthy eating. But so is there any guidance from your organization on how to change the culture or the curricula from medical schools?
It is not difficult at all. It's need a mindset and educational mindset. Even if you go to Flexner in the 20s, it's really talking about education which is based on population health. But unfortunately, this is not happening. You know why? Because we have the mentality of teaching hospital. First of all, abolish teaching hospital tomorrow. Let the student learn in the primary care setting. If you come to Imperial today in London, you know, and I can share it with you, by the way, if you send me your email, I'll send it to you. 50% of the student time is spent in the primary care. But you need to have a primary care. I didn't have chance. My brother, Mishal, actually pushed me a little bit faster than I expected, you know. But if you looked at one of the slides defining what's primary care, and we are trying to achieve that level of primary care in our countries, including our kingdom of Saudi Arabia, you know, where all the people mandatory registered with the primary care services and they have gatekeeping function. Once you have a primary care like this, it's easy to train the student. Remember that 80% of what's happening in the primary care is very much related to public health, you know, because primary care deal with healthy people, you know, and some of them, about 10%, you know, they get emergencies, another 10%, they get this and that, and some of them, they get chronic diseases. But you have the children, you have, you know, middle age, all of them are healthy, and all of them, they are in contact primary care, where you have health checks, screening, name it. This is medicine. This is where they learn. But because you're putting them in day one in a university hospital and talking about a neurosurgery, heart transplant, of course they will learn nothing about population health.
Yes, if you have any addition. Yeah.
I thank you for that. And I just want to add that there have been a few publications about lifestyle medicine within medical education, and as well as in nursing education. And I'm more than happy to share that with any of you. Or if you do want to search for Dr. Beth Frates, Frates, Dr. Melissa Bernstein, and then Kelly Freeman, you'll be able to access that article.
And I also wanted to just add that in the United States, there has been a push to actually require medical education within medical schools. We just had a big release around a rural health transformation program that is going to require nutrition education within medical schools. So hopefully in a year or two, or maybe longer, there'll be some data around how that will impact the future of healthcare and medicine in America.
Thank you. I think we've reached the end of the panel discussion, and we will start the honoring part for you just a little bit. Thank you all for your questions and for your listening. Thank you for our speakers.
Now, we will honor our moderator of the session, Dr. عش80.
Thank you all. Thank you very much for your lovely attendance, listening, interaction, and questions. I hope you scan the QR code and you fill in our evaluations and questions, and you choose the open dialogue with the speakers. Now we'll go to the short break for 20 minutes, and inshallah we will come back here at 11 o'clock, inshallah, 20 minutes. We'll see you in the next session. Thank you very much.
Yes, I can hear you. I can hear that microphone. Yeah. I can't hear that. There I can hear. Yeah.
يلا. السلام عليكم ورحمة الله وبركاته. Please, everyone, we will start our next session. So please join us. Our break ended up. So we have our next speaker, Dr. Wine Designer. He will be with us virtually, and we are preparing the Zoom link and Zoom connection. Just in a while, in few moments, we'll start, inshallah. ما في أحد يدعيهم. ما في أحد يدعيهم. المفروض انها تخلص 11:30. ننتظر الزوم يشبك. الحين نبدا. صار عنده مشكله بالزوم، قاعدين يحاولون يشبكون.
Hi, everybody again. Blue zones show us that long life is building on community purpose and everyday habits. Small action done consistently can transform how we live. What is the one thing in blue zone inspired habit you will add to your routine? Let us explore that with next session.
Start. You can start. You can start. Yeah. Thank you. Hello again, Dr. Wine. Do you hear me? Hello, Dr. Wine. Do you hear us, Dr. Wine? Hello, Dr. Wine. Do you hear me? Can you talk, please, so I can introduce you? Because we cannot hear your sound. You hear my sound? Actually, he hears us, but we cannot hear him. Can you fix his sound, please?
I'm not sure if you can hear me. I cannot hear you
Yes.
at this point.
I can hear you, Dr. Wine, now. Do you hear me? Dr. Wine?
Okay,
You
let's
hear
see.
me?
Is this working now?
Yeah. So we can start our next session with Dr. Wine, designer. He's the Chief Medical Director for Blue Zones Health and practicing lifestyle medicine physician, past president of American College of Lifestyle Medicine, and he will talk about Blue Zone Health, transforming community for healthier living. Please welcome Dr. Wine. You can
Thank
start,
you.
Doctor.
Can you hear me now?
Yes, you can start. Good luck.
Okay, I'm going to share some slides with you. Okay, I wish I could be there with you in person. I have great memories of attending the first HIL International Lifestyle Medicine Conference, as well as the third HIL Lifestyle Medicine Conference. HIL is an area that is close to my heart, and the work that the community is doing in lifestyle medicine is impressive. So I am going to talk about lifestyle medicine in the blue zones, and the objectives that I have are to describe the core lifestyle medicine philosophy. So the purpose of this is just to remind ourselves of the difference between traditional, what we call allopathic medicine, and the way that lifestyle medicine is conceived and practiced. And then we're going to talk about the blue zones. And the blue zones has two ways that they look at approaching healthcare. One is through their core 4 and the other is through their power 9. So we'll talk about those two areas. And then we're going to talk about how lifestyle medicine and blue zones work together. So first, talking about lifestyle medicine philosophy, I just want to highlight that my training was as an allopathic reductionistic physician. So I was trained right here in the middle of this slide. And the way I was trained was when a patient sat down in front of me, my job was to figure out what was wrong. So the patient would have a complaint, a concern, something that was not working well. And it was my job to figure out what that physiologic or anatomic or what the problem was, what was wrong with that patient. And then once I'd figured out what was wrong, my job was to fix what was broken. So this is the way I was trained. This is the way most physicians practice in the world right now, in this what we call allopathic reductionistic approach. Lifestyle medicine comes and says, we want to not just understand what's wrong, we want to understand a story. We want to understand what happened. We want to understand the journey that you've been on as a patient as you're sitting down in front of me. And once we understand that journey and that story, then what our job is to balance the system in front, balance the patient in front of us. So it may be adjusting their eating patterns. It may be helping them adjust to stress, but it's about balancing rather than fixing. So just to look at it another way, in lifestyle medicine, we have this foundation that's very simple things like eating, exercise, sleeping, and that approach is low risk and low cost, and it's where chronic disease reversal needs to start. There's still a place for allopathic reductionism. These things are higher risk and higher cost, but there is a place for the pills and procedures that we're trained to do as we study medicine. But the foundation, the first thing that we do, at least in the chronic disease arena, needs to be this lifestyle medicine approach, this approach of understanding the story and balancing the system. So to put it another way, when a patient walks in, they have some situation that is unknown. So we try to do some identification, and then we're gonna put them in one of two categories. One category is the known. So these are patients where we can repair that fractured bone, we can fix that known infection. There are specific things that we know what to do. That's where the allopathic reductionism goes well. But there are other patients that come in, and what they have is a chronic condition. We may understand some things about that chronic condition. If they have diabetes, depression, chronic pain, we'll understand some things about what leads to that chronic condition. But it's always multifactorial, right? So it's always where that patient has really gotten out of balance at some level or another. And that's what leads to chronic disease. And this is where we need to be bringing in this holistic lifestyle medicine approach. Chronic disease will not respond to the allopathic reductionistic, let's fix it kind of thing. That's why it's called chronic disease. Chronic disease responds to rebalancing the system, to understanding the story, and really just bringing in that holistic perspective. So we see the chronic disease epidemic getting worse and worse around the world. But if we're going to change that, we can't continue to go down this allopathic reductionistic approach. There's still a place for that allopathic reductionistic approach, but we really need to be bringing this lifestyle holistic approach if we're really going to be changing chronic disease. So just one more slide to sort of try to summarize this. What we're good at in allopathic reductionism is this concept of curing. And curing works really well if it's a known area of healthcare, if it's something that, that we know how to fix. But curing does not work well in a chronic disease area. That's where we need to bring in this concept of healing, this concept of whole person care, this concept of including emotions and spirit, going beyond the physical symptoms. That's where the lifestyle medicine or this holistic approach comes in. So I just think it's important for us to think this through, to understand this well, as we think about the chronic disease epidemic, as we think about decreasing healthcare costs, as we think about applying blue zones to healthcare as we understand it right now. So in my practice, we think about how lifestyle medicine works, and we think about these four areas. The top one and the bottom one are about relationships and connection. The middle two are recognizing that in that lifestyle medicine world, as we're trying to do that healing rather than the curing in those chronic disease arenas, we're going to be assessing people different and treating people differently. So that was a summary of the core lifestyle medicine philosophy. Now I'd like to talk a bit about blue zones. So the concept of blue zones was developed over 20 years ago, and it was developed by the gentleman here, Mr. Dan Buettner. Mr. Dan Buettner is a journalist, he is an explorer, and he became interested in trying to understand why some people live long and other people don't live as long. So he started studying different areas of the world and trying to identify where were people living who lived the longest. He eventually identified 5 areas. He got some money from the National Geographic, and he said, let's reverse engineer this. Let's understand why these people who live to over 100, why they are able to achieve those longer lives. So the 5 areas that he found, you can see them listed here. There was Loma Linda in Southern California, near where I'm speaking to you from. There was Costa Rica in Central America. There was a province in Sardinia, an island in the Mediterranean, and another island in Greece, the Icaria. And the final area that he identified was Okinawa, Japan. So all of these areas had a higher percentage of people who lived to be over 100. So Mr. Buettner started studying these more. He started publishing articles about it. There were scientific articles. This was validated, how he determined the birth certificates and length of life. And then as he started studying these more, he was able to identify some core areas where people who lived to be 100 in these areas, the kinds of things that they did. So he divided them into 4 categories. These are the same 4 categories that we talk about in lifestyle medicine. The first category was how we move. The second category was how we eat. The third category was how we manage stress and sleep and having the right outlook. And the fourth category was how we connect, how we have our social relationships. So these are the 4 areas, and they correlate very well with the core pillars of lifestyle medicine. These are, in fact, the exact same core pillars that Dean Ornish uses as he described lifestyle medicine 20, 30 years ago. They're the same 4 pillars that my practice has used for the last 10 years. And they're very similar to the core pillars that lifestyle medicine societies around the world use. Many of them use 6 pillars. They'll take right outlook and divide that into stress and sleep. And then a 6th pillar for many societies is smoking and alcohol and toxic substance exposure. The blue zones have divided their core 4 into 9 areas, what is called the Power 9 in the blue zones terminology. So we'll just look at these briefly here. The first one is move naturally. So that's make physical activity a part of your daily environment. So walk to work, walk to your friend's house, have a job where you're active at some level during your job, moving naturally. That's the first of the Power 9. The second 2 of the Power 9 go in this category of right outlook. That's understand your purpose. In Blue Zones terminology, we call that ikigai. That's a word that comes from Okinawa. Know your purpose. And then the second area under right outlook is downshift. That's work less, slow down, take vacations, know how to manage your stress, make sure you get enough sleep. The idea of downshift. The third, under the third area, the eat wisely area, there are 3. The first is eat until you're 80% full. This is sometimes called eat less. So the 80% full comes from, again, Okinawa, where they have something called Hari Hachibui, where you don't eat till you're full. We do some various kinds of fasting, other things, so that we're eating less food. This helps us to live longer. The second category under eat wisely is called plant forward or more plants, more veggies, less meat, and less processed food. The original Blue Zones has as their third category red wine on a daily basis. For Blue Zones health, as I think about this, I think that that we can separate out eating more plant forward and eating whole food. The ultra processed food epidemic is one of the biggest challenges to our nutrition. So eat whole food as grown can be put here in this third category of eating. And then the foundation, the thing that's most important from a Blue Zones health perspective is this concept of belonging, this concept of connection and relationships. And there's 3 categories where people who live to be 100 in these 5 areas categorize their belonging. The first is to create a healthy social network. This is your friend network, the people that you spend time with. And you want those people to be encouraging you in your health values and your health decisions. The second category under belong is to have a spiritual community, a religious community of some kind. And in that community, you're worshiping together. You're looking at these bigger things in life together. The final category under belong is to prioritize family. You're looking at your family. You're honoring your parents. You're honoring your children. Family is important. So these are the 9 areas where people who live to be 100 in the blue zones areas spend most of their time and prioritize their health. So I want to just finish up with a brief discussion about how lifestyle medicine concepts and these blue zones concepts can work together. So we're going to start with this slide. And the thing that I want to point out is that the lifestyle medicine movement, and we have the American College of Lifestyle Medicine listed here, but there's lifestyle medicine societies around the world who have really brought to bear the scientific concepts that we see that are important from a blue zones and a lifestyle, a healthy living, a live longer perspective. So this scientific foundation is very important. There's also a certification process. So we know which physicians, which healthcare providers understand this scientific process because they're certified. That's where the lifestyle medicine movement comes in. The blue zones movement comes in with a public awareness. The understanding of blue zones and their significance across the world has been going on for 20 years. There's been Netflix series, there's been books published. So there's a lot of public awareness around blue zones. And blue zones understands cultural change processes. And that's important as we're trying to move society, as Hael is considering the idea of becoming a blue zone. This cultural change process is important. And then there's also ways that healthcare is done differently. And this is what we now call Blue Zones Health. There's a clinical model that they have, and then there's also an economic model so that we know that this is something that actually works from a scientific perspective. So this is how we truly transform healthcare. This is how we really reverse these chronic disease epidemics that we're up against by putting all three of these areas together: the scientific foundation, the public awareness and cultural change process, and the clinical and economic models. So just to document that these kinds of things work, this is data actually from my practice in Southern California, where we put together all of those things and we get better health outcomes, we get lower cost of care, and we get happy patients. So we have documented that when we put all of this together, it actually works. So at its core about cultural change, Blue Zones gives us the opportunity to bring in that cultural change in ways that are shown to work, or ways where people live better longer, not just live longer, but live better longer. So this is the opportunity for Blue Zones. This is the opportunity for Hael and for the world in general to change our cultures, to take us away from the chronic disease epidemic and towards better health. So that concludes my talk. It's been an honor to speak with you. Thank you so much for the opportunity. Hopefully next time I can be there in person. Thank you.
Thank
My
you, Dr.
information
Wine.
for anybody who's interested in emailing.
Dr. Wine, still you hear me? Are you still hearing me? Do you hear me? Dr. Wine, you hear my voice? Hello, Dr. Wine?
I can't hear you very well, but I'm happy to stand by for questions if there's any that are there.
Yeah, we have some questions. If you hear me, we will start the questions, please. Is it a clear voice you have now? Do you hear me clearly now?
I'm not hearing your audio well.
We will try now. Do you hear me? Is it clear now?
If there's questions, I'm happy to take them via the chat, or if I can hear the audio well. Otherwise, it's a privilege to have.
Do you hear me now, Dr. Wine? Do you hear me now? I think there is a problem in the voice. IT guys, please help us. Do you hear me, Dr. Wine? There's no voice. Do you hear me? Do you hear me, Dr. Wine, now? Dr. Wine? Is it clear
I
now?
apologize. I really cannot hear your audio coming through.
Okay, maybe we'll send our questions to him later on. And if you scan the QR code, you can just write your questions to Dr. Wine and we'll communicate with him, inshallah, later on. Sorry for this technical problem. I wish that he can hear us and communicate and interact with you and answering all the questions. Actually, I write many questions for him.
Yeah, now I can hear your audio. I can hear your audio.
You can now?
Yes, I can.
Yeah, good, Dr. Wine. We'll start our question. Thank you for your nice talk and informative stress on blue zone. We'll start if the audience having any questions in the audience here, or I will ask you. Any question for Dr. Wine? Yeah, we have one question, Dr. Wine.
Thank you very much, Dr. Wine, for your informative talk about Blue Zone. Actually, I have a question of two parts. The first part, to which extent are you happy about the concept of lifestyle medicine is applied to undergraduate medical education? The second part is, to which extent are you happy about applying the latest evidence, especially in nutrition and food, in the current practice of lifestyle medicine? Thank you.
Did you hear the question, Dr. Wine?
Unfortunately, I just could hear a few words here and there, something to the extent, but I couldn't hear the details.
Maybe we'll communicate with him later on. I will take your questions, inshallah, and I will answer you. Dr. Wine, I will ask you one question. You show on your slides that since 20 years ago, you started this Blue Zone project, but in the map, it's shown only 3 or 4 countries that have still Blue Zone. So what's your next country for Blue Zone, installment or starting?
So that's a good question. And the original blue zones, it's a great question. The original blue zones, those 5 areas that we showed on the map, those were identified as places where, on average, a higher percentage of the population lived to over 100. So there was a lot of science put behind that. What the Blue Zones concept is doing now is going to different communities. So far, it's been mainly in the United States, and trying to help those communities change their culture, change so that there's less chronic disease, there's better health. And so that concept, so becoming a blue zone is a concept that a lot of communities have great interest in. And it's something that the Blue Zones original, like Dan Buettner and the original company, Blue Zones company, has developed a skill set in helping communities live better, longer. So this is an opportunity that, like I said, so far has mainly been done by cities in the United States, like Fort Worth, Texas, Scottsdale, Arizona, Jacksonville, Florida. These are areas, cities that have said, okay, we want to learn how to become a blue zone. The opportunity to do that internationally it hasn't really occurred yet. There's been some discussion in Singapore about Singapore becoming a blue zone, but certainly it would be wonderful from a blue zone's perspective to work with a community like Hael or some other community that's ready to take on the idea of becoming a blue zone.
Yeah, this is my second question is what's the opportunity for Saudi Arabia? Or let's say Hael next. What's the opportunity?
Maybe Hael becomes the next blue zone. That would be a beautiful thing.
This is what I want to hear from him. And this is maybe news, inshallah, happy news for Hael and for all the community of lifestyle medicine Hael. Actually, we have to stop here. Thank you very much, Dr. Wine. We finish with you your lecture and we finish our session. Thank you very much and see you again in the next. Thank you very much.
Thank you.
يعطيكم العافية. شكرا لكم جميعا. السيشن انتهت. إن شاء الله بناخذ break. We will take prayer and lunch break and we will come back here at 12:30 to start the last session إن شاء الله. Thank you very much.
We kindly encourage you to spare a few minutes to take a look into the activities we have set for you. The 80 seconds walking stations, the open dialogue stations, and Mr. Aja, our interactive AI avatar. Please enjoy your time. Thank you.
اي هم اصلا اول ما يشوفونك هنا احنا يشوفونا لو panel discussion بعد ما تخلص يبي يطلع اللي هو ثانك يو finish our panel discussion يبي يطلع المقدم حقنا انه في انت تكرم انت تكرمهم وتصور معك تكرم اللي هم ثلاث سبيكر زين بعدين اطلع انا كلمه حقك ينتهي ترى الموضوع مره هدوء مره
I would like to take your attention, please. We will start our next session shortly, after 3 minutes. Thank you.
Hello, everybody. We'll start within seconds. Healthy community do not happen by accident. They are built by habit support and shared purpose. And when communities drive, people drive with them. Our next session moderator will guide us through that. Dr. Thamer Al-Nasser, diabetic food specialist and director of diabetes endocrinology center at High Center Cluster, head of diabetes food unit at King Salman Specialist Hospital. Please welcome Dr. Thamer.
بسم الله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. جدا سعيد بتواجدي بمؤتمر حائل نمط الحياة، وإن شاء الله نتمنى أن نقضي جلسة ممتعة بإذن الله. The first, just would like to welcome our speaker, Dr. Mohammed Arweli. Dr. Mohammed Arweli, he will talk about the tele-rehabilitation for the future of the musculoskeletal health. Dr. Mohammed Arweli, BT and PhD, consultant of physiotherapy and founder of the Chief Clinic, officer of the Virtual Touch and director of Arweli Academic. Please welcome to Dr. Mohammed Arweli.
The timer when is it? Good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Today, I'd like to share with you the idea of tele-rehabilitation, not as a separate specialty, but as a core component of lifestyle medicine. When we think about lifestyle interventions that include exercise, weight management, stress management, we must understand that musculoskeletal health is a key component of that. And if movement is medicine, then musculoskeletal health is the gateway. So how do I go next? Tamir? Anyway, while we're waiting, for this, I would like to talk about why musculoskeletal health is a key issue, is a problem to lifestyle. The previous slide. Oh, this is forward. All right. Okay. So why should we care about musculoskeletal health? We know that musculoskeletal disorders affect about 1.7 billion people around the globe, and Saudi Arabia is not an exception. And according to the World Health Organization, musculoskeletal disorders are the leading cause of the disability. Basically, they prevent us from moving due to pain. The issue with this musculoskeletal health is that they're deeply linked to lifestyle, inactivity, poor ergonomics, excess weight, chronic stress, and even sleep problems are all linked to musculoskeletal issues. So basically, musculoskeletal pain, like neck pain, knee pain, back pain, represent a major barrier to all lifestyle interventions. The evidence says that we need to, in order to address this, we need to have an early access to physical therapy. Evidence is clear about that. Implementing the evidence is the problem, though. Basically, consistent recommendations from 11 clinical practice guidelines across different regions suggest that patients with musculoskeletal pain need to be educated about the problem, need to be reassured about that the problem will go away and it will get better, need to be prescribed exercises, need also to avoid imaging and medications. However, when we look at the musculoskeletal care system, we can realize that there is a gap in doing what clinical recommendations is saying. Basically, when we look at how people access physical therapy, we can identify several barriers. The first barrier is the long wait time to get an appointment. And then there is this travel requirement. The patient will have to drive to the clinic, find a parking spot, wait in the waiting room. And all of this basically causes delays and transition the problem from being just a physical problem into a behavioral problem. And what patients are currently doing, they're turning into rest medications and sometimes unnecessary procedures. What telerehabilitation can do is to fix this access issue. With telerehabilitation, we can overcome most of these barriers through basically same day or next day access. There is no travel requirement to the clinic. Scheduling is very flexible. The patient can be seen anywhere, anytime. And basically, it enables frequent follow-ups. So once you prescribe an exercise intervention to the patient, you can follow up with the patient every week or every other week to make sure that they are on track for their exercises. Most importantly, telerehabilitation is very powerful in removing healthcare inequality. People in remote areas can access the same quality of care as those who live in the center of a major city. The question that we get often asked is, does telerehabilitation work? Is it effective? Does it improve pain and function? And the answer to this question is that from multiple systematic reviews and meta-analyses, we showed that telerehabilitation has a comparable clinical outcomes to in-person rehabilitation, especially not only pain and function, but also improved satisfaction, improved adherence rate. So we know it works. Local data as well in Saudi Arabia. This is a study by Dr. Asbail and her team. She conducted a telerehabilitation program for people with neck pain, back pain, knee pain, and even post-operative cases. And she was able to show that people with musculoskeletal conditions improved in terms of pain and function, and they had very high satisfaction rate with the care that they received. And she could show that she and her team they were able to reach broader areas, such as Tabuk, Jazan, Al-Jawf, etc. A physical therapist in Saudi Arabia already, Dr. Mtairi conducted a study and surveyed about 370 physical therapists, asking them about their thoughts of telerehabilitation. And what we find is that majority of physical therapists are saying that telerehabilitation is effective, patients are liking it, and 51% of them plan to use it. The only barrier that physical therapists mentioned was the training. They don't have the proper training to conduct a telerehabilitation session. So does telerehabilitation fit with lifestyle medicine? In my opinion, definitely. There are 5 perfect alignments. First of all, telerehabilitation promotes movement. Basically, through video guidance, real-time feedback, and habit building. And then you can encourage self-management. You put the patient accountable of their condition. You can build behaviors with the patient. So basically, with frequent follow-ups, with frequent check-ins with the patient, you create habits of doing the exercises. You keep reminding the patient of what exercises they need to do, and you can correct even some incorrect forms of exercises or incorrect performance of exercise. You can also do screening. Sometimes not all musculoskeletal pain comes from muscles and joints, but it sometimes look like a red flag that just show up as a musculoskeletal pain. So you can screen for red flags, yellow flags, and you can even prescribe preventive interventions. Telerehabilitation aligns with Saudi Vision 2030 reforms that calls for acceleration of adapting digital health. This morning we heard Dr. Abdullah Asiri talking about digitizing health, and telerehabilitation is a key part of that. So because lifestyle change requires continuity, digital health enables continuous support. When we talk about lifestyle, we talk about trying to change people's behavior. And telerehabilitation or virtual interventions can help with that by continuous reminding them of that they need to do this exercise, by calling them every now and then, by providing them with push notifications on their phones that it's time to do the exercise. And you can even track them more objectively by knowing how many steps they walked or how many exercise programs they conducted. Recently, we published a paper about how to do a telerehabilitation session. The paper is very long, but in summary, the therapist was asked to basically assess by taking subjective exam and a functional exam, and we prescribed in that paper how to do this. And then coach, tell the patient what exercises they need to do and how to do them correctly, and then monitor. Just keep monitoring the patient while they're doing their exercises and keep following up with them. So what lifestyle medicine providers can do today? So what I think people can do is add virtual sessions to their regular in-person sessions. They can use short televisit to deliver movement prescriptions. And it doesn't have to be exercise. It can be like, let me see how many steps you walked this week or this month. Let me see what exercises you've done this period of time. Build interprofessional referral pathways. I'm a physical therapist, and I need always the help of family medicine, because some of the patients I see have diabetes, And I definitely need the help of some pain doctors to overcome some painful musculoskeletal disorder. And then use telerehabilitation to support exercise adherence and to treat musculoskeletal pain early. We know for sure that addressing musculoskeletal pain very early can help a lot, can prevent chronicity, can prevent the problem from being just physical problem, from turning it into a behavioral problem. So the takeaway, musculoskeletal pain stops movement. And if movement is medicine, then musculoskeletal health is the gateway. And what I am saying is that telerehabilitation is a powerful way to restore movement. Thank you very much.
Thank you, Dr. Muhammad, for amazing presentation. Just I want to remind you we have two QR code, one for the evaluation and another for the coaching for our speakers. The second title it will be with for the sleep, the key of longevity of for women with Dr. John Mack. He's graduated of Columbian College and Harvard Medical School in '95. Dr. Mack he's been a faculty of UCSD and USC Medical School and served of department chair at Scripps Mercy Hospital in San Diego. He's also served of chair for for American College OB/GYN District, California and Ecuador. Represent over 6,000 physicians. Please welcome Dr. John.
Great, thank you. So you'll have to help me with my Arabic. I think it's time to say Masal Hayir. It's correct? Yeah, am I good? Okay. I just wanted to talk to you a little bit about sleep. I think it is the critical pillar. I trained as an OB/GYN, and I've really come to learn over time how much the sleep that we deprive ourselves of makes all the difference in the world. So let's see if we can make this work. I want you to know three things. This applies just as much to the Middle East as it does to the United States. Are we getting enough sleep? The answer is no, we're not getting enough sleep. Is that lack of sleep impacting our health? And the answer is absolutely yes. And I'm going to talk about some specific conditions in women's lives that really does make a difference. And then I'd like to talk about some very simple things we can do, short of pills and procedures, that can address this problem. All right, you heard a great introduction. I just wanted you to know who I am and why I came all the way across the globe to come and talk to you at this meeting. So let's talk about a few of these things. First of all, are we getting enough sleep? The answer is no. And the reason probably is related to these beautiful things we have in this room called electric lights. Since the electric light came out and we could turn night into day, we've lost more than an hour of sleep. And women suffer more than men. Why do women suffer more than men? Part of it is the changes that happen in the perimenopause. Hot flashes, night sweats, wake up 3/4 of women and disturb their sleep. Women have more insomnia, more anxiety, and we'll talk more about psychiatric illness and its profound connection to sleep as well. Let's see if I got it. Who's not getting enough sleep? This is very interesting data, and I really don't have an answer for it. But in America, African women have a higher rate of sleep problems, even corrected for all of the other social variables. I don't know if that's true globally, but it's a serious problem. And the second one, in a room full of healthcare professionals, who else doesn't get sleep? Those of us, doctors and nurses, that stay up at night with patients, that have stressful jobs, that do overtime. We're all losing sleep, and we're paying a price for that lack of sleep. Also, women who deliver a baby in America, half of those women have no one else to help them at that time. We all know about obesity. Obesity, many of us think of as we gain weight, it closes the airway, but I think there's more to it than that. Obesity is causing a chronic inflammatory state that's keeping us awake at night. This is very interesting. The World Health Organization has classified night shifts as a carcinogen, a probable carcinogen. And in fact, in some countries in the world, they've actually gone so far as to compensate nurses that work at night for the risk of cancer that we've caused for them. What are some of the other problems? Significant problems in pregnancy for women that work night shifts. Preterm labor, low birth weight are all common in women who work night shifts. So I'm here with my watch on. I'm looking around the room and I'm seeing a lot of these devices on all of us. This is my watch and my data on the screen. Is this a way we can use to get data on sleep out to everyone? I think the answer is probably yes in the future. That's a very weak answer, but we know that for sleep apnea, the watch is a validated clinical instrument. We can detect it. So hopefully all of you are encouraging your patients with watches to give that data to their doctors so that then we can make use of it and do something with it going forward. More of these risks, probably the greatest is motor vehicle accidents. About 100,000 motor vehicle accidents in America are related to driving while sleep deprived. Women are often driving with a child in the car, and we can have really significant issues with this. So we do need to address it. I'll also mention most of the work that I've done is on the hypertensive disorders of pregnancy, preeclampsia, fatty liver. These are all related to sleep disturbances and possibly correctable. If we fix the sleep, we might be able to fix the preeclampsia. We'll talk more about immune issues and, as we mentioned before, some of the issues in pregnancy. So as we come here and we talk about longevity, there's lots of data on longevity. We know that many of you are working in public health. We're working on obesity. We're working on smoking. We're working on alcohol abuse, which terribly takes a lot of lives around the world. But I've never heard of a public health campaign focused on sleep. And we're losing as many years from sleep deprivation as we do from smoking, obesity, and alcohol. This is a really interesting study. I do not recommend any of you try to do it, but it does give us very valuable data. They took patients and they not only deprived them of sleep, but they also dripped live viruses into their nose before going to bed. What did they find? We all know this. This is all common knowledge. But what they found was that by giving the virus to people who were sleep deprived, they were 500% more likely to get sick. So good night's sleep really is the cure to many of the illnesses that we suffer from. Sleep apnea. It's very different in women. It's not the same as in men. They don't report the same symptoms. They don't get diagnosed by the same techniques, but it's a very significant cause of issues for women. And we have very good treatments for sleep apnea. The number one cause of women not getting a good night's sleep is actually a man snoring in the bed with them. So if we could correct the men's sleep problems, maybe we could help the women. One other thing I should say that I think is really important is the perimenopausal period, probably because of a shift of muscle to fat, is causing more airway problems for women. So be very sensitive to women as they approach the perimenopausal years. All psychiatric conditions have a sleep problem. Very proud, maybe I don't know if I can get a step ahead of myself. We already talked about some of the statements from our college on medical issues. We are going to have a statement on major depressive disorders and lifestyle medicine. And I was happy to work on the sleep part of that. And all psychiatric illnesses have a sleep component. And in every case, it's bidirectional. What does that mean? That means if we fix the sleep, we can fix the psychiatric illness. If we fix the psychiatric illness, we can fix the sleep. It's really amazing data. And I'll also mention that the most effective treatment is not a pill, but is cognitive behavioral therapy for insomnia. Works very well, and it's our first-line treatment. Last year, some of you were here, I came to talk about polycystic ovarian syndrome. I consider that an epigenetic disease. It's a disease not in our genes, but in our epigenetics, and it's very sensitive to sleep. Also, bidirectional. If we fix women's sleep, we can help them. This is the #1 cause of infertility in women, especially in the Middle Eastern part of the world, and it's growing rapidly. So if a woman is having problems with fertility, they should be evaluated for polycystic ovarian syndrome, and they should be evaluated for their sleep as well. We think that the chronic sleep deprivation and the hypoxia from closing the airway is causing these women to have a chronic inflammatory state. Okay, so now what can we do about it? We use this term sleep hygiene here. And let's just go through these. Whenever I come into a hotel room, I love the Holiday Villa, but there were little lights in the room. I had to cover them up when I get into the room. And I also bring, well, we can get you an ACLM sleep mask. I bring that with me anywhere I go to cover my eyes at night. But what can we do? We can cover those lights. And the one thing which I think is the sleep killer is the cell phone. Cell phones should not be in the bedroom. Televisions should not be in the bedroom. And certainly not work email should never be in the bedroom. These are things that are killing our sleep. Minimize the bedroom noise. The temperature in Celsius should get down to around 18.5 Celsius for you to get a good night's sleep. Increase your daytime sunlight. Decrease caffeine. I cut my caffeine off at noon, and that can be challenging in some parts of the world. Avoid high sodium foods. Stay hydrated, but slow down on drinking water in the last couple hours so you're not getting up. And as we mentioned before, cognitive behavioral therapy is really our best bet for sleep deprivation. Does this work? And I actually think it works very well. Training patients on sleep education has significant improvements in their ability to sleep. And everyone I know has sleep problems, and everyone I know is doing something that could be better with their sleep habits at night. So these are things we need to do. When we have both cognitive behavioral therapy and sleep hygiene, we're seeing very substantial improvements in patients' ability to sleep at night without taking a single pill. Okay, now I'm going to try to pronounce this word. This is something I learned about as I was getting ready for this talk. Qailula, which are midday naps, am I correct? Hopefully no one is having one of those naps right now while I'm speaking to you. But right afternoon, after a meal, getting about 20 minutes. There has been fantastic research into this for improving mental alertness. The keys to it are keeping it short, about 20 minutes, and doing it at midday. If you take a nap late in the evening, it may disrupt your sleep and keep you up at night. If you take a nap that's longer than 20 minutes, again, it may keep you up at night. So some other things we can do. There's an old song in America, when I can't sleep, I count my blessings instead of sheep, and I fall asleep counting my blessings. Do you all know this from Walt Disney, I think it is? Yeah, this is a wonderful thing. So even before we'd done any research in this, we found Mickey Mouse knew that this could work for you as well. Counting your blessings has really been shown, or just simply writing down what you're grateful for every day, has shown to improve our ability to sleep. Because so often, what keeps us up at night? It's our head, it's our mind. Thinking about our blessings instead of our problems will help us sleep at night. Secondly, forgiveness. And when you think about forgiving people before you go to sleep, and I think about writing this down and making it formal, the most important person you have to forgive is yourself. Getting rid of the things that you blame yourself for, you shame yourself for at night, can help you get a good night's sleep. but also letting go of the grudges that we have against others. That will also, and this is scientifically proven, to help us sleep. So think about these. Lastly, I'll end. Kelly did a fantastic presentation from the American College of Lifestyle Medicine on the resources we can give you. Some of you may know Dr. Ayman Afifi, who was here last year, but he worked with me. He's at the Prince Sultan Medical Center in Riyadh, and he helped us translate these handouts into Arabic. We have one on menopause in Arabic. You can take a screenshot, or we can distribute these if you contact us. We have one on polycystic ovarian syndrome as well in Arabic, which is free to you to use. And we have one on gestational diabetes as well, which can help you. And there is certainly a sleep component to gestational diabetes. So with that, I'll end, and I'll try again to say a couple words to you. Tizba al Hayr. So I'm wishing you a good night. I'm seeing some smiles in there, so I did okay with that. And with that, I'll just say shukran, and I welcome any of your questions. Thank you very much.
Thank you, Dr. John. The last topic for our session today, it will be the the last evidence on how can protect ourselves from the immunity. Number one, anemia, heart attack, with the Dr. Khalid al-Nimr. Dr. Khalid al-Nimr, professor of cardiology, faculty of medical Al-Imam University, intervention, CT, nuclear cardiology, phase 10 of college medicine, the member of the National Saudi FDA advisor, board member of Saudi Heart Association. Also, Dr. Khalid al-Nimr, founder of the Cardio Academic Committee in Saudi Hair Association. Please welcome Professor Khalid al-Nimr.
وين التايمر؟ اوكي. السلام عليكم ورحمة الله وبركاته. First of all, I would like to thank the organizing committee for inviting us. And certainly I'm very proud that this meeting is organized from A to Z by Saudi young people efforts. There was more than 500 people who work day and night the last 6 months to organize this meeting. So I want to raise the hat to them and tell them thank you. We are very proud of you. The second thing is, I'm going to tell you important things also about lifestyle. Well, before we start, how do you move the slides? الأخضر طيب. While they fix it, I want to tell you an important thing. As a clinician who practicing interventional cardiology, I have no problem that lifestyle changes is very effective. We know that. This is الأحمر. أيوة. We know lifestyle intervention is very effective. There is no doubt about it. This is ABCs of medicine. But what I want to know from the people who specialized in lifestyle medicine is to tell us, how do you stick to lifestyle changes? This is the challenges of human being. There was a major study. All these are practicing people, healthcare professionals. So there was a major study called the Diabetes Prevention Outcome Study. And it's more than 3,000 people. And it was comparing metformin versus lifestyle changes. And it was published in New England Journal of Medicine 2002. It was one of the major trials in lifestyle changes, randomized trial. Lifestyle changes is very effective compared to metformin in preventing diabetes. But after 10 years, only 5%, 95% were not sticking to the weight, 7% target. So 95% were not able to stick to the plan. 70% of them, they were not adherent, a meaningful adherence to the program. It is the nature of the human being cannot stick to lifestyle. So what we need from our lifestyle specialist to tell us, what did you invent to let human being stick to a lifestyle changes long term? This is what make a difference for me. Don't tell me it's very effective. I know it's very effective. But tell me something new that the human being can stick this for life. This is what we need to know. Okay, so the burden of cardiovascular diseases in cross-world is increasing. And in Saudi Arabia, there was around more than 130,000 of acute MIs in 1 year. And we see it in all different cities in Saudi Arabia. And there is, so the Ministry of Health has done a wonderful program in primary care, in primary management and intervention of acute myocardial infarction. How to prevent MI? Well, you cannot prevent MI if you don't know the risk of MI. Okay, so how can we know the risk of MI? The risk of MI, you need to have a calculator. You have to have an equation. The equation from different guidelines, we have several equations. The most commonly used equation across the world is the American College of Cardiology equation, the ASCVD equation. There is the new equation coming from the European Society of Cardiology, the SCORE2 and SCORE2OP. But the problem is those equations are not getting from our own data. We do not have recalibrated equations from our own registries. We do not have our own local MENA and North African and Middle East data. Even if you go to the European guidelines, the SCORE2, they excluded the Middle East. You cannot apply people in the Middle East because of the ethnicity. They are not recorded in those equations. You cannot use them. Even in the American equation to estimate the risk, still ethnicity of the Middle East are not included. So we need our own data, simply. And I think Dr. Abdullah Asiri have a plan in having more registries and more equation to estimate future cardiovascular risk by our own data. So this is an important concept to have. The second thing is you have any patient who comes to you who's asymptomatic. Of course, those people who comes to you, diabetes or hypertension, or people who have CKD, those people are high risk. It's out of the equation. You manage them. People or the people who have strong family history of hyperlipidemia, it's considered as has high risk. We are talking about people who's asymptomatic, don't have diseases. From 40 to 70 years, you should have an equation. You calculate the coming 20-year risk. So there is people who is below 5% of cardiac events. This is low risk. From 5 to 7.5, this is borderline risk. From 7.5 to 20, this is intermediate risk. Above 20 is high risk. ليش طيب أسويها? Why should I do it? Low risk, he's doing good job, just follow him up by assessment every now and then by scoring. Intermediate risk, you have to risk stratify them. You have to risk stratify them either to high risk or low risk. How can I risk stratify them? Well, you have either you do stress testing or do coronary calcium scoring or do myocardial perfusion of them. Search for target organ damage, but you have to risk stratify them. Do not accept a patient to stay in the intermediate zone. يا يروح للhigh risk zone and you manage him, or to low risk zone and he follow him up. High risk zone, you go up with the intensive medical therapy. Low risk zone, you just follow him up. This is an important concept. Okay, so what else I can tell you? Of course, diabetes is a high risk per se. So everybody, I do not accept diabetes patients come to my clinic without statins. Please, please, and please. Statins has been proven to lower the risk of the coming first MI by 23%. You should use statins. There is 2 conditions in diabetic person without hypertension. Their LDL has to be below 70 and it has to be 50% lower from the initial stage. بمعنى جايني المريض جايني ب2 LDL وديابيتك وهايبرتنسف. 50% is 1 and it's below 1.4. حلو. My target is 1. 1 is around 40. So you have to use high dose statins to lower his LDL to prevent the first MI. The issue is we cannot rely on only lifestyle medicine. The world now going to integrative medicine, complementary medicine, lifestyle with the medications together. Encourage the lifestyle, but also don't forget the medications, okay? Especially, we have issues with the lifestyle long-term, stickiness of the people around it. Okay. What else I can tell you? So the polypill, this is the things you have to know. 4 numbers and 4 habits of each patient. The 4 numbers are, number 1, what is it? For each patient, you should know what? Their LDL cholesterol, صح? What else? Hypertension, number. What else? Fasting blood sugar or hemoglobin A1C. And what else? The last number, weight. So these are the important 4 numbers. I come to the resident, and if he doesn't know this number about any patients, then this is a major issue. Then you have 4 habits. The 4 numbers and the 4 habits summarize the whole program of lifestyle. The 4 habits is your smoking, your sleeping, your eating, and your moving. There you go. These are the 8 numbers, the numbers and the habits which control the lifestyle. This is called the polypill. Now, the target of the LDL move different from one person to another. But if you want to tell me what is the most effective method for preventing MI, what is it? It's combination. There is no only one step to give you the strongest thing. The strongest thing is to combine. Stop smoking, do exercise, do a healthy lifestyle, do your vegetables, and so on. But the next to the combination therapy in preventing MI is what? Quitting smoking. Quitting smoking is number 2, the strongest single factor for preventing MI. أعيده. إيقاف التدخين هو أقوى عامل منفرد في منع حدوث الجلطات. Again, stopping smoking is the most single strong risk factor for preventing MI. Then you have the dyslipidemia, you have the hypertension, and so on. Okay, so what else we have? So this is emphasize the healthy diet where you have the vegetables, the fruit, legumes, nuts, and whole grains, and fish dishes. And I think Dr. Mishal already told me that you'll have people coming from everywhere creating for you healthy dishes for the people. So this will be an excellent opportunity. Blood pressure management. Your blood pressure target in a normal human being should be below 120/70. I know this is a very low number, but from 120 to 140, this is, we call it pre-hypertension. Pre-hypertension classified into low risk and high risk. Low risk, lifestyle modification. High risk, medications. Above 140/90, you treat them with medications. This is in summary. Okay, so lipid. It's not accepted at all for any human being to have an LDL with even low risk above 100. You have to be below 100. Now, if you are below 100, it depends. If you are high risk group, you should be below 55. Yani diabetic. I do not accept diabetic to move around with LDL of 100 and 110. He has to be below 1.7, below 70. He has to. إذا كان معاه hypertension لازم يكون below 55. إذا كان معاه MI, he has to be below 55. إذا كان معاه stroke, he has to be below 55. If he has 2 MI, ولا 1 stroke and 1 MI, he has to be below 40. So you don't hesitate. And I have seen people giving atorvastatin 10. Anybody who comes from diabetes, atorvastatin 10. No, you go with the guidelines. Don't hesitate to use high intensity statins. Atorva 40, Crestor or rosuvastatin 10 or 20. Go to the target. Your target is below 70. If your LDL is 180, you cannot reach 70 with atorva 10. No way, or atorva 20. Don't be lousy in using high dose statins. Hit them hard if you want to prevent the MI. Okay? So this is an important message. This is the same thing where you have to check for your lifestyle changes. So what message I can now regarding aspirin. Aspirin, the old story was not to give aspirin everybody above 40. No. Now people who have a high risk, you calculate by ASCVD. Above 20, high risk score and low bleeding risk. Then you give him aspirin. Like you don't give him to somebody who has a high bleeding risk. Why? Because bleeding kills more than thrombosis. There is no point of pushing the patient into bleeding. And the first rule of the physicians is to do what? Do no harm. It's not your job to improve the patient's life if you don't prevent the harm from him. So you have to prevent bleeding. Now, if the patient is low risk, he doesn't need aspirin. If the patient does not have previous MI or stroke, he doesn't need aspirin. If the patient is not a high risk, he doesn't need aspirin. If the patient has a high risk and he has high bleeding with HAS score, don't give him aspirin. If the patient is elderly and he uses blood thinners like warfarin or Nuax, don't give aspirin because the bleeding aspirin will increase the risk. Unless you have very high risk of thrombosis. So you have to measure the benefit and risk in each patient. So now each one of those subpopulation has a new statement. وأكبر مشكلة عندنا, we have one of the biggest problems is psychiatric patient, depression. We have a tendency to ignore depression and anxiety management. Depression and anxiety are very well related together with cardiac patients. And screen them, please, and treat them, please. It's undertreated. The prevalence reported to be around 30% of anxiety and depression. And it's kill the young people, destroy their lives, destroy their jobs. So don't hesitate to support our patients and even healthy people. To the extent that the European Society of Cardiology last year produced a statement guidelines on how to manage cardiac patients with psychiatric disorder. They have to be managed together, the psychiatric diseases and the cardiac patients together. It's part of the rehabilitation program. We have to look into the patient together, not a disease per integrity or leave it to family medicine. You have to treat, especially the people, the high-risk diseases. And I think I came to my last slide, which is we need a team approach. We need a special care for people who have poverty and low access to healthcare system. And I think Dr. Abdullah Asiri already commented on that today. And please use the digital tools to calculate the risk and to manage the patient. And thank you very much.
Thank you, Dr. Khalid, and we are ready for our discussion. Just we want to go for a few questions for everyone because we don't have a lot of time. The first question for the first speaker, for Dr. Muhammad, we have a question asked, how you can deal for the difficulty of patient in virtual and through of the virtual clinic, how you make a plan and treat him as a rehabilitation plan, and how to be explaining and dealing with the way patient.
So thank you for the question. Your question goes to how patients are basically treated in telerehabilitation mode. Essentially, while we promote telerehabilitation, in the paper we published, we indicated that there are individuals who are fit for online care only, so they can completely be examined and treated online. And there are those who are fit for a hybrid mode, so they can be examined online, but treatment needs to be in person. And then there are those who need to be examined and treated in person. Our estimation indicate that 40 to 50% of people are going to be fit for the online care only. What we know is that 80% of the diagnosis comes from patient history. So if you listen to the patient carefully, you can figure out what exactly is going on, and you can determine what structure is affected, and you can prescribe exercises accordingly. Some physical examination can fully be conducted online, either with the help of the patient himself or the help of a caregiver. Some interventions can also be conducted online by the patient himself by showing them videotaped exercises or YouTube exercises that they can perform on their own. Or if they have a caregiver, the caregiver can help with doing the intervention. I think one of the key approaches, one of the key advantages of telerehabilitation is the continuous follow-up with the patient, because it removes the burden of patient coming to the clinic and telling you what they feel and then seeing what you have to say. You can just continue to monitor the patient remotely very easily through a video or text even. So that this is how
Thank you, Dr. Muhammad. Thank you. because that question is coming from our rehabilitation. He said we are dealing with a lot of patients outside of our city. About that, he want to ask about this difficulty. Thank you, sir. Dr. John, just when we are see for your presentation, it was for the sleep hygiene. You mentioned for the minimize flight, but almost of our people, it's like to sleeping with the dark rooms. What do you think about that one? How to be the relation for the dark or minimum of light sleeping?
So I understand the question. So what do we think about minimizing the light in rooms?
Yeah.
I think it's critically important. The first thing I saw in my hotel room here was a television screen.
Mm-hmm.
And I wonder if there is anyone under the age of, say, 30 who doesn't have their cell phone next to them at night. I think cell phones are really causing us terrible, terrible problems. And by the way, it's not just the light, it's the specific kind of light coming from the screen. It's that blue light coming in. So I think what we need to do is really go around and try to get these sources of light out of our rooms, and then also sleep with a mask. To be honest with you, I think there's an added benefit of a mask because it's kind of a trigger. When you put it on, it's part of that ritual that gets you to go to sleep at night. So cover all the light sources, especially electronic lights, and then also sleep with a mask. I hope that answered your question.
Yeah. Thank you, sir. For Dr. Khalid, just we will ask about because we have a lot of our cultures. We know about we talking about diabetes, how to prevent the diabetes, how to be preventive of diabetes from the lifestyle, from the eating, from. But what's your message for education to prevent the hypertension for our culture and our people?
Okay, thank you very much. Well, as you know, hypertension in Saudi Arabia, the percentage around 29 to 30% of the population, they have hypertension. And the number is increasing because the prevalence of obesity is getting worse and worse all over the world, not only here. So the number one message to control, prevent the blood pressure, hypertension, is to control the weight. Obesity is the number one enemy for hypertensive people and for any society. So I think we should have educational programs in the schools and family educational programs, how to have a healthy diet and how to have controlling the weight of kids, getting them to move around, get them exercise programs. This is a major issue. There is data in the literature with having pediatric obesity of 40%, 45% in some schools. So we need to control this epidemics of obesity to control hypertension. Number two is to control the salt intake. As you know, salt intake has been correlated with cardiovascular events in general, but mostly with hypertension. We have to teach people how to use low salt diet. I know people, there is people who doesn't taste at all any meals without some salt on it, but we have to make it a habit. It's the human is the son of habits. Whatever he used to it, he will continue on it. Regarding smoking, also is very effective, but I think also exercise program has a major role in preventing hypertension. As I mentioned before, lifestyle changes and intervention are very effective, but it's very effective medication with a short half-life. We need to invent lifestyle medication for long half-life. This is what we should work on. We need lifestyle changes in a way or another can stick with a human being for a long time. People can accept it. I know the education has a rule, but we need to go ahead, step ahead in spreading those things. But the more important things in our community is the screening programs. You have to screen for hypertension. You will be surprised. Around 50% of hypertensive people in Saudi Arabia, they discover hypertension accidentally, because it's asymptomatic disease. So screening programs also make a big difference in discovering hypertension and controlling it.
Okay. Thank you, Dr. Khalid. Thank you, everyone, for a nice and amazing session. And just want to see, welcome to Hail, and we hope, inshallah, see you next season, bi'idhnillah. Thank you.
Now, we will start honoring the session 4 speakers. Dr. Mohammed Al-Ruwaili, Dr. John Paul, Dr. Khalid Al-Nimr. Please. I would like to ask Mr. Abdurrahman Al-Traifi to honor our session moderator, Dr. Thamir Al-Nasr. That concludes our last session for today. Thank you all for being a part of this inspiring first day of Hail's 4th International Lifestyle Medicine Conference. It's been a day full of insightful sessions, engaging discussions, and new connections, reminding us of how small changes in lifestyle can create big impacts on our health and well-being. A sincere thanks to our incredible speakers, moderators, and of course, to all of you for your energy and participation. We've only just begun. Tomorrow brings more exciting sessions and engaging opportunities to learn and grow together. Until then, enjoy your evening, recharge, and we'll see you tomorrow. Thank you for your time.